तो आपका कर्टन बंद करना पड़ेगा मैडम.
I know, that's what I'm thinking. It's a bit of an effort, but I think I should do it. Okay, let me go do that.
So, ma'am, we are live. So, can we start the webinar?
Just wait for 2 minutes.
Okay.
Once either Alpesh sir or Rishikesh sir will join.
Ma'am, sir's phone is continuously busy.
His phone is always busy.
Even
And
Alpesh
Alpesh
sir
sir is also on speaking to somebody. He's also not picking up the phone right now. So we can start, ma'am, because it
I
is
think
already 5:10.
I think
Dr.
so.
Monica, but first speaker Dr. Nandita madam has not joined yet, no?
Ma'am, sir, Rohan has सांगितलं me. Madam is Rohan is going to give her talk.
Okay, done. Start please.
Yes.
That's a good replacement.
Support staff, please start the webinar.
Omkar, can we start the webinar, please?
Yes, sure. So, good evening, all the faculties in this Public Awareness Committee Fogsi program, episode 9. So, I welcome the coordinator of this webinar, Dr. Monica and Dr. Shatabdi. So, Dr.
Thank you, Omkar. No formal introductions, please. I am very happy to announce that this is the 9th episode of the Public Awareness Committee webinars. And this time we have selected our theme as infertility and a talk on environmental factors because June is an infertility awareness month, as well as we will be celebrating the Environment Day on the 5th of June. That is why the topic has been selected such. This is the brainchild of our chairperson, Dr. Priyanka Roy, ably supported by Kalyan Garamde sir, who is the national coordinator for the PSC committee. Thank you, sir, for your blessings always. I now request Shatabdi to please introduce our guest of honor, Dr. Rishma Pai ma'am.
A very good evening to everyone. Thank you, Monica. I think Dr. Rishma Pai needs no introduction over here. We all know her very well. Ma'am is a consultant gynecologist at Leelavati, Jaslok and Hinduja hospitals in Mumbai. She has been the former president of Fogsi, of IAG, of ISAR, as well as of MOGS. She has also received the honorary fellowship, FRCOG, of the Royal College of Obstetricians and Gynecologists in London. And she has been awarded with multiple awards, including the Lifetime Achievement Award by the Indian Society for the Study of Reproduction and Fertility in 2022 and ISSRF in 2021. We welcome you, Rishma ma'am, and we would be very happy to have a few words of encouragement from you, ma'am.
Thank you. Thank you. Good evening to all of you. Wonderful to meet all of you again, virtually, even though it is. Happy to know that very soon Dr. Rishikesh will be joining us, and of course, Dr. Alpesh. So you have a very important webinar going on with all the senior Fogsians participating, all the past presidents, Dr. Alpesh and Dr. Nandita will be giving a talk. So I think it's really adds value to it and just proves how important these webinars are. And the fact that you are on your 9th episode today really does underline the dedication and the sincerity with which you all have been conducting these webinars. We all know that Priyankur, as the chairperson of the Public Awareness Committee, is very, very dynamic, extremely committed, and he has totally learned from Kalyan. We know, Kalyan, you changed the whole attitude and the whole look of the Public Awareness Committee. I think after you were the chair, the whole committee became really, really visible and really, really prominent. And I have to say a special word for Monica. Monica has made sure multiple calls, reminders, and has really been working hard for this program. So really wonderful to see all of you, Monica, Satabdi, working so hard towards all these events. And I can see all of you rising up the ladder and being the leaders very, very soon. I am really happy that today you've chosen infertility as a subject. Of course, you know, it's very, very close to my heart, having been president of the Indian Society of Assisted Reproduction, as well as really been practicing infertility for so many years. It's something which is very, very dynamic, constantly changing, and which is why we always need updates about it. Even the very subject that you all have chosen today as your main talk on environment influencing infertility, I think that's so topical. Just a few weeks ago, WHO announced that the prevalence of infertility has risen to 17%. All our textbooks used to say 10% of couples suffer from infertility, and now it's 17%. And we know also that infertility has been labeled as a disease. So this disease is increasing, and possibly environment has a huge role to play in it. And which is why in the few years that we have been practicing infertility, we have seen the prevalence increasing from 10 to 17%, which, if you consider the number of couples involved, is a huge increase. And so many, many factors, of course, the age, the couples getting married really late, deciding to have children late, their lifestyle, the alcohol, the smoking, the stress that they're undergoing, and environmental influences, all are contributing towards infertility being, becoming a huge issue and a very, very common problem today. And along with the problems, obviously, come the solutions. And alongside, we have wonderful technologies such as egg freezing coming in, embryo freezing, which is giving these couples opportunities to preserve their fertility, along with many, many other advances that have happened. So I think it's very, very nice that you all have selected this, your discussions on cases, which is very, very practical, on, all the updates in infertility will be really, really useful to all the people who have logged in and are listening to how the infertility management is changing over the years. So all the best to all of you, and congratulations on your 9th. And I will be there for your 19th next, okay? So we hope that you'll have many, many episodes more. All the best. And I think with the enthusiastic team behind it, you will do very, very well in the future. So congratulations, best wishes, and have a wonderful session.
Thank you so much, ma'am, for your blessings. We move ahead with the formal inauguration. I would request all the dignitaries to please join for the key lamp lighting. Omkar, can we please have the Saraswati Vandana? There's no audio, Omkar. Can we get the audio, or we should move ahead, Omkar?
The audio problem is not there. I don't know.
Yeah, oh, no problem. Thank you. Thank you so much, Reshma ma'am, for joining in. Alpesh sir is also stuck up with an emergency. He has just sent a message. So we now move forward to the academic of this webinar. Our first talk is by none other than Dr. Nandita Palshetkar madam, and the chairpersons are Dr. Ajay Mane sir and Dr. Narendra Gupta. I would take pride in introducing both our chairpersons today. Can we have the slides on cut, please? Dr. Ajay Mane sir is the Vice President Fogsi elect the year 2024. He is also the member of the National Inspection and Monitoring Committee of the PCPNDT through Government of India, the Fogsi. He is a medical legal consultant since the last 18 years, and he has been the official chairperson of the AMOF website for the last 4 consecutive years. We welcome you, sir. Our next chairperson is Dr. Narendra Gupta, sir. He's a consultant gynecologist and IVF specialist at Vivekanand Hospital and Fertility Center. He is the past secretary of the Jaipur OBGYN Society. He has been the editor of Infertility Update newsletters, and he's the chairperson of ISAR Rajasthan chapter. We welcome you, sir, and we request you to please carry forward the academic session.
Thank you, Dr.
I can see Nandita madam has joined. Ma'am, can you please speak something before Rohan talks?
Dr. Monica,
Yes,
we
ma'am.
just logged in for Dr. Nandita for the presentation. So
Yes,
she's not there. So I think.
Okay, no problem. Yes. Narendra sir, can you please introduce Rohan sir and madam in short so that we can start the talk?
Yeah,
Ajay sir will be joining in at the 5
thank
minutes.
you, Dr. Monica. And it's my privilege and pride to introduce Dr. Nandita Palshetkar, who is a star in our ISAR as well as in Fogsi. She has a lot of credentials. She is an eminent IVF specialist with more than 28 years experience. She is medical director, Bloom IVF. She heads more than 7 centers all over India. Specialized in RT from world famous IVF units in Belgium and Copenhagen. She is pioneer in India for latest techniques and technology, Jixi, laser hatching, blastocyst culture, etc. She is a PG teacher, delivered more than 85 orations and more than 900 talks. She has been president of the ISAR 2022, president of the IAGE, and many other organizations in India. She is state level president of AMOX in 2020 to 2022. She would be speaking on environmental factors affecting the male and female fertility. Here I request Dr. Nandita Palshetkar to start her talk.
Dr. Narendra sir, thank you so much for the kind introduction of my mother. Unfortunately, she's been stuck in an emergency, so I'll be delivering the talk.
Okay, Rohan, so nice to hear from you. Today I was listening your talks somewhere on the YouTube. So it was such a nice thing to. So I don't have your credentials at this point.
Don't worry about it, sir. Thank you so much for the kind introduction of Dr. Nandita.
Yeah.
She is truly an inspiration for all of us.
Yeah.
I want to thank Kalyan sir also for inviting me and allowing me to deliver this talk on her behalf. He's always been a great mentor for me, always guiding me whenever needed. And I know always that if I just pick up the phone, I can just call him up and be like, Kalyan sir, I need this help. And he's always there. So thank you so much, Kalyan sir, for always being there. And Dr. Monica, thank you so much for inviting me as well. Veena, can we please have the presentation so I can begin? Yeah.
Hello.
Oh,
Can I
Dr.
just say-
Rohan sir, can we have Pfizer's comments
Yeah,
before?
please.
Yes,
Your
Hello.
well, we welcome you, sir, for the 9th episode
sorry, I
of
was
this
a bit
webinar.
late.
Yes, sir.
But thanks. So
Yes.
thank you, and I would like to first of all congratulate Dr. Kalyan Parmade, Monica Obermath, and our Priyankur, who is I think abroad. I don't know where he is, but for this webinar, and I don't want to come in your way. Madam is going to talk about environmental factors. Dr. Nandita, Rohan, and all are there, so I can see a lot of my friends in this thing, but I'm in the car, so Dr. Ajay Mane is there, and Doctor I can't see properly, but a lot of my friends are there, so I would like to not take much of your time. I would like to only say that we have now nearly reached the halfway mark of my year as a Fogsi president, and a lot of new exciting ideas are there. I wish I could be there for 2 more years as president, but I have to leave in 7 months' time. So like there are 12 more conferences, and I want to invite all of you for the final important conference in November 24 to 26 in Geo. I'm having the conference, so I want all of you to be there. It will be like a mini ICOJ, hopefully, but we'll have 1,000 people. But I wanted to get all the important stakeholders, and we wanted to do a lot of joint, like with all other organizations like IAG, then ISAR, IFS, ISOPA, PCO Society, all these. So we can have side events and we can have a great time. So just book your time slot from 24 to 26 November. It's a new venue, and the same venue will be using next year 2025 from the 8th to the 12th for the AICOG. The convention center is very well built by the Ambanis, and though this will be like a small trial to see how the venue is, what we can do, how we will be evolving it. So I hope that all of you will be there for having a great time and having a good learning. I'm also planning to do some public health. We just now attended the Cape Town meeting on what is known as Align MNCH, Maternal and Child Health, which is the biggest. It was the biggest meeting in the world on maternal health. And then I also attended in Phuket. I attended the population meeting. So there are 5 big funding areas in the world for health. One is malaria, second is tuberculosis, third is HIV, fourth is maternal health, fifth is contraception, and so these are the 5 main funding areas. And now there are other smaller areas like vaccination and all that have come in. So these are the areas which are important for all of us. So because we are in public, like maternal is a very part of public health. So I wanted to explore these side areas in this conference, and we will escalate these concepts in the January 2025 conference. So we can have more broader. Plus, I was also planning a wellness section as well, which can also be escalated in the future, because we are now slowly transitioning from curative to preventive kind of services, well-being, wellness. These are new concepts that we should bring in into our conferences. So I'll not take much of your time. Thank you for inviting me, and looking forward to listening to Dr. Nandita and learning from her. Thank you.
Thank you so much, sir, for joining us and encouraging us always. We are blessed to have you as the president, Fogsi, sir. Thank you so much.
So now
Rohan, sir, you can continue now.
Yeah, sure. Rohan, you can continue.
Thank you so much, sir. Thank you, Dr. Rishikesh Pai, sir, for your inspiring words. So I'll be talking on lifestyle and environmental factors that affect female infertility. Veena, can I have the next slide, please? So basically what the entire thing is that Dr. Rishma just spoke about how stress, nutrition, sleep, they all are very important part of managing the fertility. As you can see, that fertility has been on an increasing trend over the last few years. And now even WHO has said that it's become 17% as compared to the 10% that has usually been there. Veena, can we have the next slide? The slides are not changing. So I think there's a little bit of an issue with the slide change. Anyways, I can still continue talking. So when we look at lifestyle has been received great attention linking poor lifestyle habits such as to affect female infertility. If we look at pollution, the chemicals and pesticides, we look at the illicit and pharmaceutical drugs, even the recreational drugs which are there. Smoking and drinking, we all know, has always been a part of the issue. A disturbed circadian rhythm, such as like our disturbed sleep cycles, stress, eating disorders, obesity, improper eating habits, socioeconomic factors, STI, sexual violence, and even something as simple as mobile phones is something that has been really been affecting our female infertility quite a bit till now. Veena, can we go to the next slide? So when we look at it, when I look at the obesity at the start, we see that early onset of obesity, it can lead to menstrual irregularities anovulation, insulin resistance, PCOS. And this almost increases the risk of infertility 3 times more. When we look at obesity, it leads to high LH levels. Insulin resistance decreases your SHBG. It increases your androgen levels. Peripheral fat also gets converted to estrogen, affecting oocyte maturation. We've seen that with obesity, ART cycles are also massively affected. We see that when the BMI is on the higher side, we require more doses of gonadotropins, which increases our risk of OHSS as well. We also see that there are slightly poor quality embryos that develop. That means the number of embryos of which we get are of a lesser quality. There is also the stimulation can take a little bit longer than what we require. And if the patients, if what we talk about the lifestyle modifications, if they are able to do that prior to starting our ART cycles, it always helps. Dina, can I have the next slide? So honestly, lifestyle modification is something that I always have been talking about. This was me back in 2020 and me a little bit even lesser now in 2022. Lifestyle modification does make a big difference. Veena, can we have the next slide? Now, eating disorders. I've talked about one spectrum of obesity, but when we look at eating disorders, we have to look at undernutrition as well. When we talk about malnourishment, it's not just about overeating, it's also about undereating as well. It's more the eating disorders such as your anorexia, your bulimia, where the patients eat and then immediately throw up. Binge eating disorders, where we are like talking about just stress. When we look at just eating, oh, we've had a bad day, patient's gone into PPH. What's the first thing we'll do? After the surgery is done, come on, let's get a quick bite that releases the endorphins. That's also a very poor eating disorder, which a lot of people suffer from. So we've seen that it's more common in the urban population than the rural. These eating disorders have also seemed to be coexisting with mental health as well. So these patients suffer from either depression, stress, and anxiety. Why am I talking about all of this? Is because when we look at the fertility point of view, this can lead to amenorrhea, oligomenorrhea, even anovulation, irregular periods, and even luteal phase defects as well, which in turn are affecting the fertility. So these patients require a more multidisciplinary approach in order to treat them. And therefore, we have to make sure that we are involving a psychologist or a psychiatrist along with the dietitian, along with the gynecologist as well. Now, nutrition. We have to choose right. We have to live well. We've all gone through the different fads of diets which have been there. Veena, give me the next slide. We've gone through the keto diet, your intermittent fasting. We've seen so many diets which have been trending, you could say, on social media. But what do we have to eventually do is we have to look at a balanced nutritional diet when we go about treating these patients. We can see that a poor nutrition causes a direct decrease in the GnRH pulse. It can also cause ovulation disorders like luteal phase defect and amenorrhea. The HPO axis can also detect decreased glucose levels. Therefore, hypoinsulinemia can cause improper maturation of the follicle, resulting in anovulation or even poor quality oocytes or even cyst formation. Our polyunsaturated fatty acids play a very important role in maintaining the integrity of the cell membrane of the oocyte. So therefore, when we look at the dietary and nutritional factors, I always tell my patients that, okay, all these fad diets which you're going through are fantastic. They'll help you lose weight short term. But if you're looking at long-term health and nutrition, a balanced diet where you're having about 3 to 5 meals a day, small meals, is the ideal way of not only losing weight, but also maintaining the weight that you've lost. So these are important factors that we play this. Now, stress. I think what I have seen is that stress levels currently in the population are at an all-time high. We're looking not only at the stress of working couples where work is taking most of our time. We look at them trying to burn the midnight oil, trying to ensure that their work takes more priority than anything else. Besides work, we also look at just the stress of having baby itself, where they are over stressing about the fact that
they want to conceive and they're unable to conceive. Because of this, the stress increases. Now, why is stress important in our lifestyle? Because when stress-induced hormone changes can cause mood swings as well as malnourishment, as I spoke before. Chronic stress can result in increased CRH levels and therefore affect the FSH and LH levels, which in turn affects the quality of the follicle. Diagnosis of infertility, social stigma related to infertility, repeated IVF failures are also stressful as well. And high level of anxiety you will probably see in most of the patients undergoing infertility treatment. Now, when we look at these stress levels, again, I always insist that the patient should at least meet a counselor, if not a psychiatrist. Now, the law anyway states that a counseling session with a psychologist is of must prior to any treatment. So I think this multidisciplinary approach towards the treatment of fertility along with stress also helps. Now, circadian rhythm. As doctors ourselves, we know how bad our sleep cycles are with labor patients as coming at 3 in the morning. But this also relates to couples who are working hard and who are burning the midnight oil. I see a lot of patients with so much stress involved because of lack of sleep. They are probably reaching office at 7 in the morning, leaving at 10, 11 in the night, continuing their work. So when we look at this altered circadian rhythm, it leads to menorrhagia and dysmenorrhea. Melatonin circulates the circadian rhythm, and melatonin may be responsible at various levels in the reproductive system. However, we still don't know what the mechanism is. However, I tend to use a lot of melatonin in my practice because not only does it help the patients get a good sleep rhythm as well, but the melatonin itself acts as a powerful scavenger molecule and it reduces the antioxidant levels as well in these patients. So I'm using melatonin currently for all patients of poor ovarian reserve as well as PCOS patients as well, because there have been current research studies which have shown that melatonin does affect the oocyte quality in a good way, especially in PCOS as well as POR patients as well. Can we have the next slide, please, Leena? Now, alcohol. I think alcohol has been something that has been a controversial topic. There have been many studies that have shown a link between alcohol and infertility. But there is exactly a reference point where you can say that this much alcohol is okay and this much alcohol is bad. One study has shown that more than 3 drinks at one occasion can increase the infertility. And another study has shown that 1 drink a week to 5 drinks a day can increase the time to pregnancy. Alcohol increases your estrogen levels, decreases the GnRH pulses as well as the GRH levels as well. Excessive alcohol intake can also cause hyperprolactinemia. Alcohol is something that is highly subjective. So each person's tolerance, the effect of alcohol on each person's metabolism seems to be different. So it's difficult to say to what extent. I think it's important that we tell all our patients who are trying to conceive to be off alcohol for at least a minimum of 3 months. As we know that the cohort of follicles that is selected is almost 3 months in advance prior to the egg that grows in that month. So whenever we're looking at an IVF cycle and we're selecting the cohort for the stimulation, that time we see that alcohol that the cohort that is chosen is almost the cohort chosen is 3 months prior. There's no way of affecting it. So all our medications which we give, DHEA, we give our antioxidants, we look at it at least for 3 months because that's what's affecting the oocyte quality as well. May I have the next slide? So when we look at cigarette smoking, that is something that I think is not even something that needs to be talked about in detail because we all know smoking affects oocyte quality, affects the ovarian reserve. Nicotine decreases the estrogen bioavailability and inhibits the aromatase activity as well. It increases the FSH levels and reduces the estrogen levels, altered progesterone levels as well. It decreases the ovarian reserve, but the exact mechanism of how it's affecting is not exactly known. They are talking about superoxygen radicals, which can be affecting the oocyte quality as well as causing oxidative stress and damage to the ovaries, and therefore it's working, but the exact mechanism has still not been established. Again, all patients trying to conceive should be told about to stop smoking. Now, caffeine. This is something that is obviously a very major point which we need to speak to patients. Excessive caffeine intake can cause menstrual irregularities. However, excess isn't defined. But excess caffeine intake increases your SHBG, inhibits oocyte maturation, and increases steroid synthesis. Now, when we talk about caffeine intake per day, now in pregnancy itself, do you know that you're allowed 200 milligrams of caffeine per day in pregnancy? So that's generally what I try to play a little bit on the safer side. I always say don't take more than 100 milligrams of caffeine per day. So even patients who are trying to conceive, we don't need to tell them to get off coffee, but we need to ask them to limit the amount of coffee they take per day. When I talk about caffeine, I'm also talking about tea as well. When I look at caffeine intake, now I had one patient who used to drink 6 cups of black coffee per day. So these are patients who need to be counseled about their caffeine intake because this is going to affect the fertility as well. May I have the next slide? Now, socioeconomic and demographic factors. If we look at it, infertility earlier used to be more prevalent in the urban population. But now the rural population as well, if we go to see, is beginning to have an increase in incidence of infertility as well. Studies have shown that higher literacy, cumulative, the more you have studied, the more you have educated, the fertility rates have declined. So why is this? It could possibly be a correlation in the sense that when we're looking at the urban population, they're looking at settling, finishing their education, maybe looking at the family planning protocols a little bit earlier. They want to conceive later once they're established in their work, once their careers have been settled in, their income has been fixed. So in these manners, we see that the urban population seems to have increased. What we don't realize is that the Indian woman, the ovarian age, basically the ovarian aging is much faster than our Western counterpart. So we say whenever all our patients are Googling and going, they see that, oh, 35 is the age. But what they don't realize is that the Indian population, the ovarian aging is starting at about 30 to 32. So we have to explain to them that even if they are looking at delaying the fertility, we now have to give them options of oocyte freezing, counsel them regarding. Dr. Rishma Pai also said that we've made so many advancements in the field of oocyte cryopreservation that these patients need to be counseled. I look at my own this colleagues and my own fraternity. All of the younger generation, like myself, I had my child at the age of 30. So when I look at it, because I had the knowledge and know-how, I had frozen my embryos when I was 26. I got married early and I knew that I didn't want, so we froze our embryos at a much earlier age. So looking at that manner, it gives an opportunity to actually counsel these patients. So by this, we can possibly reduce the effect of fertility on these patients and give them sort of a fertility insurance as well. May I have the next slide? Violence against women. I think this was a topic which was brought up in last year's Foxi's and I think that's something that needs to be been brought and been spoken about. I think the Public Awareness Committee is something that is been doing this for quite some time since Kalyan sir's chairpersonship, and I think Priyankur also is taking this up quite well in its current status. STIs can cause tubal block. We already know that. There's an increased risk of ectopic. HIV positive women have lower fertility rates. Sexual violence can cause physical and psychological trauma to these women. Sexual and physical abuse at a younger age can increase even the chances of endometriosis. And these all together do end up decreasing the fertility rates in women and therefore reducing the chance of achieving motherhood at an earlier time. May I have the next slide? Mobile phones. Now, this is something that has boomed. We've seen now our iPhones, our Samsungs, our Android phones, they always give you the amount of screen time that you're doing per week. However, does it really have an effect on our fertility? Currently, there are no human studies. However, animal studies have shown that radio frequency and electromagnetic fields can reduce AMH, disrupt the oocyte development, and increase the oxidative stress. vitamin C intakes can seem to have a protective effect as well. So, to what extent mobile phones, as the andrologists say, they don't want to keep their mobile phones in the pocket. The cardiologists say they don't want to keep it next to their heart. As for female infertility, I would say don't keep it in your purse. I think you need someone else to just carry it for you. Can I have the next slide, please? So I'm done with my presentation. Just a few take-home messages that I would like to give. Lifestyle and environmental factors do affect female infertility. However, modifications and leading a healthier lifestyle improves the chances of pregnancy naturally a lot. However, our knowledge regarding this topic is highly under-researched. We need more data. And once we get more data, we'll be able to give more take-home messages to our patients, to our doctors, and ensure that just simple lifestyle modifications can make a big difference to female fertility as well. Thank you so much for a patient hearing. I'm really happy that I was able to deliver this talk, and I hope I've done justice to the Public Awareness Committee as well. Thank you so much.
Thank you, Rohan. You have done so well, citing all the causes of factors which can affect fertility, basically, and your talk was very precise, very nice. If there are any questions, you can have them.
Ajay sir, can we have your comments also?
Yeah, basically, Rohan is not the emerging star now. He has already established star on the horizon of infertility. It seems after listening his talk, he has covered every aspect of the lifestyle modification and everything. And as he stressed out, physical and mental stress, and every point goes towards the stress. Mental stress is very important, basically, as he mentioned earlier. And the age factor is nowadays very important. Late marriages, and earlier it was said that 20 to 30 is the best age for the conception, and that is missing nowadays. And circadian style, Saturday, Sunday nights, parties, and regularly sleeping late and waking up late is again one of the major causes. And nutrition, of course, Ayurveda says 90% of the disease cause, 90% of the disease causes is dependent on the nutrition. As Rohan correctly said, that nutrition must be a proper and timely, basically regular, because it is a part and parcel of circadian rhythm, regular interval of the food. And very best lecture by Rohan. Thank you, Rohan, and thank you, Monica, Kalyan Bhai, and Priyanko, for giving me chance to be a chairperson for this important lecture. And yeah, thank you.
Thank you, Narendra sir, and thank you, Ajay sir, for sharing the session. Thank you, Rohan, for delivering this lecture on such a short notice. It was a wonderful insight. I now request Shatabdi to please carry forward the academy session with the first panel. Shatabdi, are you there? Can I please make it full screen so that I can introduce the moderators for the panel discussion today? Dr. Kalyan Baramde sir and Dr. Monica Gupta. Our expert for today is Dr. Leela Vyas ma'am. Dr. Kalyan sir has been the past chairperson of the Public Awareness Committee, Fogsi, for the year 1922. He is currently the Joint Secretary IAG and the convener of the mission Save the Uterus Fogsi. He is also the executive member of MSR and a chairperson of Infertility Committee amongst for this present year. And he has been the president IMA Latur for the current year. We welcome you, sir.
Thank you.
I also welcome Dr. Monica Gupta. She is the West Zone Coordinator for the Public Awareness Committee, Fogsi. She is the organizing president of AlwarCon. She has also been the past president of Alwar OBGY Society and the Fogsi Achiever Award of the West Zone Yuva Fogsi at Ranthambore. She is a Dhira Master Trainer and a Manyata Assessor. We welcome both of you to moderate this panel discussion. I would now introduce our expert panelist, Dr. Leela Vyas ma'am. She is a senior professor and unit head, IVF consultant, member of the Research Review Board, SMS Medical College, Jaipur. She is also the HOD of the Department of OBGY's CKS Hospital, Jaipur, and a senior consultant at Cocoon Hospital. We welcome you, ma'am. Our panelists for today Dr. Vishal Gude, Dr. Snelata Dubey ma'am, Dr. Sailesh Jain sir, Dr. Charu Johari, Dr. Bansi Shinde sir, Dr. Manjari Varsankar, Dr. Deepak Desh, and Dr. Priya Kadam ma'am. Can I have their introductions? Dr. Vishal sir has passed MD from Goa University in 1994. He is a consultant OBGYN and director at Aster Hospital. He has been practicing in Goa for the last 25 years with a special interest in endoscopy and IVF. We welcome you, sir. Dr. Snelata ma'am is a gold medalist in physiology, and she has done her MS from GR Medical College, Gwalior. She also holds a fellowship in minimal access surgery from the Jodhpur. She is a diploma in gynecological laparoscopy and hysteroscopy from UKSH, Germany. She also has a fellowship in assisted reproductive technology from Delhi. She is the current joint secretary of INA Gwalior, and she is an executive member of Fogsi, Gwalior Society. We welcome you, ma'am. Dr. Sailesh Jain, sir, is a consultant at Shubham Care Hospital, Jaipur. He also has a diploma in advanced gynae endoscopy from France, and he is the secretary of Association of Gynae Endoscopy Society of Rajasthan, the IAG chapter Rajasthan. He is currently the treasurer of Jaipur Menopause Society. We welcome you, sir.
Thank you, ma'am.
Our next panelist is Dr. Desh Deepak. He is currently the director of Rajdeep Fertility Hospital and Research Center at Kota, Rajasthan. He is the organizing secretary of the West Zone UA Fogsi Conference 22 and the organizing chairperson of the State Conference of Endoscopy in 2019. His special interests are endoscopy, high-risk pregnancies, and ultrasound. We welcome you, sir. Our next panelist is Dr. Charu Johari, madam. Yes. She has passed from the King George Medical University, Lucknow. She holds a fellowship in ART and reproductive medicine, and she's received a gold medalist in her post-graduation. She's a central head at Indira IVF Alwar. She has been the past secretary of Alwar OBGYN Society and the receiver of Foxy Achiever Award in 22. We welcome you, ma'am. Our next panelist is Dr. Bansi Shinde. He's been the past president of the Ahmednagar OBGYN Society, the chairperson of the scientific committee amongst Shirdi 2016. He has been a faculty of state national conferences, and he is the director of Shinde Hospital and Ankur IVF, Ahmednagar, Maharashtra.
Thank you very much.
Sir.
Thank you.
Our next panelist is Dr. Manjari Varsankar, madam. She holds a fellowship in minimal invasive gynecology from Beams. She also has a fellowship in infertility. She's currently the director and consultant at Bhide Hospital, Test Center, Navi Peth, Pune. We welcome you, ma'am.
Thank you, Dr. Monica.
Our next panelist is Dr. Priya Kadam, ma'am. She's the director of Yashoda Hospital and Maternity Care Akhluj since the last 11 years. She's been the director of Vatsalya Test Tube Baby Care Center at Akhluj and the past president of Akhluj OBGYN Society. We welcome all of you, and I'm sure this would be a very important brainstorming session because it is a case-based discussion. Over to you, Kalyan sir and Monica ma'am.
Thank you. Welcome, everybody. I thank Dr. Priyankur and Dr. Monica for giving us this opportunity to present a panel on fertility enhancing endoscopy. So I welcome everybody for this panel. It is open to all. Anybody can take any of the questions and you can add whatever is relevant for this panel discussion. I welcome all the panelists and they are esteemed panelists, endoscopic surgeons and IVF consultants. So firstly, we'll discuss certain medical conditions and then afterwards we'll start discussing the fertility enhancing endoscopy. My slide is not moving. I'll go again, back. Okay. So all uterine abnormalities like polyps, submucous leiomyoma, intrauterine adhesions, chronic endometritis, and congenital anomalies have been reported in around 20 to 45% of the patients who are undergoing IVF cycles. Endometrial polyps accounts for 32% among subfertile women. Implantation failure in 16% of the cases, and associated with endometriosis in around 46% of the cases. The uterine septum, the prevalence is 1 to 2 per 1,000 to 15 per 1,000 patients. The true prevalence is difficult to ascertain as many are asymptomatic. There is a case you can find around 21% of the cases with infertility septum is there. Incidence of early miscarriage in 41%, late abortion and premature deliveries in 12% cases, malpresentation, fetal growth restriction, placental abruption, and perinatal mortality is common as obstetric complications. Asherman syndrome, the prevalence of Asherman syndrome in infertile population is around 4%, and infertility occurs in 45 to 50% of the Asherman syndrome. Early pregnancy loss is around 25 to 40% in Asherman syndrome. Preterm delivery is about 23 to 30% in Asherman syndrome cases. The placenta accreta is around 13%, and ectopic pregnancy chances are around 12% of the cases. So endometriosis and infertility, the incidence is around 30 to 50%. It causes pain, infertility, although 20 to 25% of the patients may be asymptomatic. So here I am with Dr. Monica, madam.
Good afternoon, everyone. Welcome to the panel on infertility. And now we are going to discuss our first case. 29 years old woman coming to the OPD with a history of pain during menstruation and increased bleeding pattern with primary infertility for 3 years. Her BMI is 24. History of regular menstruation in past, now complaining of altered bleeding pattern with slight increase in bleeding during menstruation with sometimes mild spotting in between. On examination, PV finding was normal and day 2 hormonal analysis were normal. USG showing evidence of intrauterine solitary lesions of about 1.5 centimeter. The sonography picture is like this. Now, what is your diagnosis? Who is going to take the case?
Welcome, Leela.
गुड इवनिंग एवरीवन गुड
आपको कमेंट देना है हर केस के बाद मैडम.
अच्छा अच्छा ठीक है
Yes. So we start with Dr. Anjali.
Yeah. This most likely looks like a endometrial polyp. To confirm this, day 2, day 3 is not the right time. We need to call the patient in a mid-follicular phase, especially if you're doing a peri-ovulatory scan. That time, the polyp is elicited well. If you have a 4D, you can also do a pedicle sign and elicit the vascularity of the polyp. If you are having only a 2D and maybe not a very advanced setup, then you can also do intrauterine saline infusion to delineate the entire polyp along with the markings, but it is not very common when you have excellent radiological modalities. So once you've confirmed the polyp, if it is now this patient more than 1.5 centimeter, looks like a central polyp with a feeder, needs and a symptomatic patient with intermenstrual bleeding would warrant a hysteroscopic polypectomy.
So what we have to do is a transvaginal ultrasound is the most important one. We should always go for that, and we have to diagnose it. And more importantly, MRI is having very limited role in this. We can easily diagnose these things by the ultrasound.
Ma'am, I would like to add something.
Yes.
To differentiate this endometrial polyp from thickened endometrium, we have to look for the feeding vessel, and the Doppler reveals more correctly these endometrial polyps.
That she has told ki we have to do the Doppler. We always put a color Doppler probe at that time, and we can see the things.
Yes.
Now, what will you do? How will you manage the thing?
Dr. Bansi.
Yeah, Kalyan, I will like to, means already all workup has been done. So I will like to go for hysteroscopic resection of the polyp. And I think it will work in such cases.
So you want to use cold knife or monopolar resection?
Just Caesar.
Okay, so resection or endometrial polypectomy by
Yeah.
scissors.
Yeah.
Anybody has any different views?
As it's type 0, only scissors will work, and also patient is infertility patient. So we all think that we should start with scissor only.
Right, for infertile patient with polyps, surgical removal is recommended because it allows natural conception and even opportunities of conception increases in ART cases. Monica, madam.
Glycodyline inhibiting sperm oocyte binding and natural killer cell activity is very high. So in the cases of endometrial polyps, so we have to remove them to increase the fertility of the patient. It is speculated that fertilization and endometrium receptivity may be altered by increasing glycodyline production in the uterine cavity of patient with leiomyoma and polyps at the time when uterine glycodyline levels should be absent or low. Presence of polyp may alter HOXA10 and HOXA11 gene expression, establish molecular markers of endometrial receptivity, and thus impairing endometrial receptivity. So the removal is very important. So the hysteroscopy polypectomy is the gold standard one for the treatment, and there does not appear to be differentiate whatever hysteroscopic method we use, Caesar, bipolar or monopolar current.
Can I make one point if I'm allowed to do so?
Yes, please.
Yeah, most of the time the literature always mentions the size cutoff, but what has been our experience is size cutoff is definitely one of the vital markers, but the location of the polyp is also very important to be considered, because suppose a polyp is less than, it's a sub-centimeter per polyp, but it is coming exactly in the line of implantation, whatever the literature says, but we'll be more comfortable doing a hysteroscopic polypectomy with the scissor and then go ahead for a FET or for the fertility management. So size is not the only hard and fast thing, but the location and size together would make more sense to the situation.
Dr. Manjari, I'd like to add or question you one type that, are you doing hysteroscopy before every IVF procedure?
Not before all IVF procedures, because I'm doing a 4D scan TVS for all the patients with Dopplers. So whenever we have any pathology which is suspecting in line with a polyp, especially as I told you, perifollicular, you can peri-ovulatory scans, we can immediately pick up the polyps, etc. If you're having any suspicion of a septum or recurrent pregnancy losses, recurring implantation failure, those patients for sure we have to post for a pre-IVF hysteroscopy. But by and large, all the patients do not warrant a pre-IVF hysteroscopy. Even the literature says so.
So good 4D scan is important and there is no need of putting a hysteroscope, but you have to be cautious that those patients with 1 or 2 IVF failure is always better to put a hysteroscope. And you find that 10 to 30% of the cases, you might find some polyp or something lying inside the uterine cavity or intrauterine adages. So now, Shailesh, you have done a good polypectomy, but there is a difficulty in the specimen retrieval. This is a 4 centimeter polyp which you are removed. Are there any ways of removing this dancing polyp or a large polyp? How you go about this?
Sir, first and foremost thing is we can leave these polyps inside. So these come with the menstruation and these reduce in size. So after some time they can come out. And there are other things also. We can have our old ovum forceps. And then we have nowadays, we can cut them into pieces and then we can remove them.
So in Indian scenario, will patient will be happy keeping a polyp inside? Dr. Desh
Counseling, sir, counseling.
Yeah, Dr. Desh Deepak, what is your views about this? Welcome.
Counseling is very important.
Yes,
and we call the patient after a week. Again, we do rescan, and sometime before discharge, I put some mesoplast also.
Yeah.
To protect and automatically polyp is expelled out.
Yeah.
Otherwise, in follow-up, we can do office hysteroscopy.
If the patient doesn't give history of polyp being coming out of her vagina, right? Dr. Priya, when you planned pregnancy for this patient, Dr. Priya Kadam, Akluz, can you unmute, please?
Yes, sir. Yes, sir. Good evening, sir.
Yeah, when you planned pregnancy for this patient after polypectomy.
So we can plan, she can plan immediately.
Right? Anybody differs in this? Dr. Manjiri?
Sir, I'd like to say that
I
we should
think
wait
what-
for at least 6 weeks or 8 weeks.
Okay, if there is
I would actually like to disagree with this.
Right.
I have also done, I mean, this is the, we can
We
say
have
the
also
jug-
done in the same
yeah,
cycle.
and we can
IVF
say,
is going on.
yeah, Jugad also, you can say I have done in same cycle, patient has conceived
know.
and delivered. So basically, if you're not using, I think it is what we use.
It is what
if you're not
instrument we-
using energy,
Right,
then you
right.
can safely go ahead because you're just dissecting with cold scissors. It's a localized thing. If you're using energy, then what Dr. Shailesh said is right. It is better to wait for a cycle if you're using energy. So I think
Right.
it depends on what you are using, but otherwise we have done in same cycle and patient has conceived.
Yeah, so many times you start stimulation on day 3, they pop up these polyps, and then you can do a office hysteroscopy, minimum trauma to the endometrium, and then you can do the procedure in the same sitting also. But if you use an energy source, then uterine cavity takes healing of 1.5 months to 2 months. As Dr. Shailesh has rightly said, you have to wait for 2 cycles. But there is insufficient evidence to advocate a specific length of time before woman should conceive. Thank you, Dr. Monica. Now we'll move on to the second case. 34-year-old. Yes, please, Dr. Leela Vyas, madam. So sorry. Yeah, you can have expert comments, ma'am.
Yeah, everything has been covered. Yes, very nicely described. But one thing is preferably only the scissors to be used and avoid that your any energy source because we are treating with the infertility patient. Another thing is while doing sonography, you just see that if bigger polyps are there, whether it is of mucus type or the fibroid polyps are there, because that we have to see. Because that time it becomes a difficult because of the mucus polyp then can be removed immediately or it can be come out. Because in infertility, we are not going to dilate our internal os. We are doing with the 2.9 scope. We are going with that. So we can't expect that bigger fibroid polyp will come automatically. And it will remain inside autolysis. It will take another 1 month or 1 or 2 cycle it requires. Because we used to leave this infertility patient, we avoid to keep polyp inside because the patient will be not satisfied. And again, we are in hurry. Definitely in the same cycle, we want to do some either transfer or we have started that. As you have rightly said that in between, sometimes the patients are coming, the husband coming from the outside, and we are doing only planned ovulation induction with the IUI. The husband has to go, especially those army persons and BSF persons, they have their problems. That time, yes, in the same cycle, you just put your scope, take out the polyps, because initially you see that there is nothing. Small polyp you have seen, you think of that the spot will be there. So these are the things. Another is definitely the type of that. Those who are very expert in doing sonography, definitely the type of mucus polyp will come with a fibroid polyp, definitely require energy source, and that can be taken with the bits. So you should not cut first from the stump. You have to take out the bits of these polyps and then, yes, the small bits you can keep inside, they will come automatically outside. And very nicely answered by all the experts. And no, can proceed with the
there is another perspective in this. If you get not this patient, if you get multiple polyps on hysteroscopy, yes, so many times you find 6, 7, 8 polyps. Yes. So Deshdeepak, what is your policy? How you go about for such patients? Can you unmute, please, Dr. Deshdeepak? You need to unmute, please, Dr. Deshdeepak.
With multiple polyp, we can use the resectoscope, cold knife type. Right? Don't use the current, and we can sometime because our process will be the fast if we use the resectoscope. Without even
Dr. Shailesh? Small polyps, 6-7 polyps, most of the time because of the hyperestrogenic status.
Yes, sir.
Anybody has
And
tried
after that, we
anything
can use
else?
the GnRH after the completion of
Okay.
the.
I can add something.
Then lastly, you will add. Dr. Deepak or Dr. Shailesh, please.
Sir, I'd like to go for with resectoscope and.
Dr. Manjiri, what is your view in infertile cases? Or you agree with the resectoscope thing? Dr. Manjiri, you are
Sir,
not audible.
Sir, it depends actually.
I
if
would
all
not.
are-
I would not like to use energy resources until and unless it is
Right.
absolutely crucial, because you have done a 4D scan which shows you the vascularity. So you're very sure, and you can be patient and remove the polyps with the help of cold scissors, because that patient again, after a month, maybe the next cycle or so, even if you wait, she is ready for with a good endometrium. If we use the energy sources, sometimes it happens that after 2 to 3 months we are trying, but the endometrial priming fails and you don't get a good endometrium with a very poor vascularity.
So what we do in our setup is use MVA cannula.
Yes.
So like for MTP, you use MVA cannula,
Yes, sir.
and just 2 times you aspirate this content and you find there are all polyps in your ball, and that is how you can prevent the uterine endometrial lining injury. Dr. Leela Vyas, ma'am, your expert comments.
Yes, very rightly said. I was also coming to that. We have different size of cannulas. Even you have gone with the 2.9, means with sheath that has the 4 millimeter. You can use even the 5 number cannula. Just to put, there is no need to dilate it. Just put the cannula, use your MVA syringe and take out these. And same times, one thing is, as no resectoscope, you with the scissors, you just cut down from their base. And that will give, if you see in sonography, it's again increasing. 1 cycle of norethistone, you give that will be go, because it is because of a hyperestrogenic conditions. So you prime with the progesterone, and then can be the thinning of the endometrium will be there.
Thank you, Dr. Leela ma'am and all panelists. Now we move on to the second question. This 34-year-old lady came to OPD with history of profuse bleeding during menstruation with passage of clots. She's a case of secondary infertility for 4 years. Ultrasound shows a type 2 submucous fibroid of 3 into 2 centimeter size. What is the next step? Who is going to talk about the role of ultrasound, fibroid mapping, and how it is going to be helpful for all for the next management? Dr. Priya, you will take this, or Dr. Charu, you are going to take this?
So this is a case of submucous fibroid probably, and type 0. And if it is just bulging into myometrium also, that is type 1. If it is more than 50% in the endometrium, myometrium, that is type 2. So we have to do the grading very nicely, because if we are going to operate these fibroids, we should know what is the exact location and what should be the approach. For type 0 and type 1, it's a very good histoscopic fibroid removal is very good, and we can do it very easily. But in cases of type 2 fibroid, if it is big, we can go either with histoscopy or with laparoscopy also. And so in this case, because this is a symptomatic patient and this is a big fibroid in the uterine cavity, we'll go ahead with the histoscopic removal of this fibroid.
Very rightly said. Why you have to remove fibroid is because they do influence fertility, mainly based on the favorable pregnancy rate obtained after myomectomy. Also, submucous fibroids, hysteroscopy cannot only diagnose these pathologies accurately, but also enables same-setting myomectomy. Submucous fibroids in particular significantly reduce implantation and pregnancy rates of ART, and submucosal fibroids distort the uterine cavity, have been found to carry a relative risk of 0.3% for pregnancy and 0.28 for implantation after ART. So now you have mapped the fibroid, and the size I have mentioned is 3 into 2 centimeter. Dr. Shailesh, if this size was 4 centimeter, are you going to go ahead in a single setting or 2 setting? And what are your tips about doing a submucous fibroid myomectomy or teeth Ari.
Sir, I basically decide with LASMAR or step W classification nowadays.
Very
It
good.
includes this size, topography, and extension of the base, penetration, and lateral wall. So I discussed with the patient prior,
Can
and I
you,
counsel him.
for the benefit of everybody, can you just talk about this LASMAR classification in detail?
Yeah, sir, LASMAR classification, also known as step W classification. There are
Right.
the score is 0, 1, 2. The things are size in centimeters. 0 is less than 2, 1 is 2 to 5, and 2 is more than 5. Topography is sir, low, middle, upper, depends on the position. Then extension of the base is less than 1/3 to 2/3, and more than 2/3. Then penetration is there, as we in this classification, FIGO classification is also there. 0, less than 50%, and more than 50%. And +1 score we add for lateral wall. So if the score is 0 to 4, so this is group 1, that is low complexity hysteroscopic myomectomy we can do. 5 to 6, we consider GNRH prior use, and we consider 2-step hysteroscopic myomectomy. We counsel patients, ER second उसमें देखना पड़ सकता है. And
So
if
this
it's
is
7
very
to 9,
important. Dr. Shailesh has told very important that if the score is 0 to 4, that can be finished in a single setting.
yes.
And if score is 5 to 6, it might require 2 settings. So counseling prior to surgery is very important. And Dr. Shailesh has enumerated it very rightly. And if score is more than 7 to 9,
Yes.
then better to go for a laparoscopic myomectomy. Dr. Shailesh, please continue.
Yeah, so this is counseling is very important, sir. In such cases, if it's 7 to 9, we say that we'll remove it laparoscopically, so it's better. So always counseling first for these patients, that we may require 2-step hysteroscopy, and the alternative in 7 to 9 is we will do by laparoscopically. So LASMAR or step W classification is very important nowadays.
Very rightly said. You have to decide everything prior. Counseling is important. You can keep a blood reserve if the fibroid complexity is there. And mostly importantly, you have to have different steps to manage the excessive bleeding during the surgery, that is transcervical resection of myoma. Dr. Bansi Shinde, how you manage the excessive bleeding during the TCRM? Dr. Bansi?
May I add something?
Yes, please.
Sir, he is not online. You can ask somebody else.
Sir, everything is taught by Shailesh. I wanted one thing. In few cases, I used the vasopressin at the base of the myoma before starting the resection, and I found good results. And
Wonderful results, sir. Wonderful results.
And first,
What are the 2 benefits of using vasopressin, and where you inject?
I inject with the own pickup needle at the base of the myoma. And then what I do, first I use the Collins knife and cut this endometrium, and then I resect the myoma. So there will be less fluid absorption also. Right? First, so even before starting, I cut the upper portion either with scissor or with the Collins knife, and then like enucleation of the myoma, and then resect it. Sometime even I left the myoma, suppose
after opening the pseudocapsule, you keep the myoma back sometimes. After opening the pseudocapsule, you mean to say?
It is easy to even we can prevent the less damage of the endometrium also.
So vasopressin diluted is used. You can put into the intracervical lesion at 8 o'clock and 4 o'clock position. That has 2 good effects, that the fluid absorption is less, as well as it is going to prevent the excessive bleeding during the transcervical resection of the myoma. So now, how we are going to manage the fluid overload? Dr. Charu, you are doing a hysteroscopy?
Yes, we are doing here.
Or Dr. Priya can take this. Yeah, Dr. Charu. Dr. Charu,
Yes, we have to we have to be very much careful about the fluid overload, and we have to measure how much input we have given to the patient, and we should measure correctly the output also. We should measure in the buckets, and we should ask the assistant to close up nicely about the overload, means how much is the fluid deficit now. And if it's more than 1.5 liter, we should defer the surgery, or we can stop the procedure. If there's no bleeding, we can ask patient to go for the second setting, so that we can prevent the complications for the fluid overload.
So one person dedicatedly should be looking after the fluid overload, preferably regional anesthesia, because early signs can be told by the patient. That is why a spinal anesthesia will be preferable in such patients. And thirdly, you should have the system to monitor the fluid deficit. Anesthetist plays a big role. If he says stop, please stop the surgery at that point, because he is the one who is taking care of all the factors. And now,
Sir,
yes,
sir,
please, you can add, Dr.
sir,
Shailesh.
yeah, sir, in Rajasthan हम लोग कहते हैं कि तुम एक छोटू को रख लो, छोटू फ्लूइड पे ध्यान रखेगा, तुम छोटू का ध्यान रखो.
Very good.
And nowadays there are machines also available that have
Right.
sensors actually.
Instrument.
Yeah, instrument with sensors. So these are jars are there, and jars are sensing actually the outflow, and they are giving beeps at particular intervals.
That's very good. You have to be investing into the OT. Newer technologies is going to help you. Now, Dr. Priya Kadam, if you are doing a myomectomy, it is incomplete and you have a perforation. You are doing always with a cautery, either bipolar resectoscope or monopolar resectoscope. Now, how you are going to manage hence further from that point, once you find that you are into the peritoneal cavity?
So we should abandon the procedure.
Firstly, how we are going to decide which patients might have perforation? Those patients with lateral wall myomas, those patients with anterior wall myomas, posterior wall myoma is slightly difficult to perforate. Those are difficult location, corneal fibroids. There are chances that you have to be really.
Sir, if we are using Histromat,
right.
We are using Histromat, it will give the signals that the pressure has suddenly decreased.
Right. So now the pressure has decreased. What next?
So we should abandon.
Yeah, abandon the procedure. Next step is what?
See for the vitals.
Right. Talk to the anesthetist, see for the vitals, and then Priya, Dr. Priya, are you going to put a laparoscope or no?
Yes, sir. Should
Right.
put a laparoscope and see if it is actively bleeding, and also check for the if there is any injury to the adjacent structures.
Injury to the bowel. So it's very important that medico-legally you have to see that, put a scope, see whether any white patches are there on the bowel, and adequately take a surgeon friend's help in this procedure. The important is myomectomy is not important at that point. You can do it after 2 months, but you need to do it right medico-legally. Dr. Leela Vyas, madam, your expert comments about this case.
Yes, myomectomy, that I think most of the part has been covered. That counseling is very important. But lastly, you said that the complication can arise. So these each and everything we have. And the firstly thing is the mapping is very important. That to be the ultrasonography done by yourself, or if you are not doing in your hospital, you are not registered for the sonography, you just ask your sonography diagnosis person, your friends, that you show me that you have to invest your time in mapping. So pre-operative preparation is very important. By that mapping, you can see that where it is located, and then plan and then take counseling to be done. And again, the size which is there, the small fibroids, which are the submucous and all, then definitely to give a nick, you increase and decrease the pressure. That is, you do the massage, which we call it as small fibroid, submucous fibroid, which is in the grade 1, which is partially embedded into this. These will come out. So don't be hesitated in removing these. But yes, definitely, if it is grade 2 and all scoring system, which Shailesh has already mentioned, so I'm not going in detail that. So these parts to be taken in correction. And yes, as Dr. Deepak also said that he is giving a nick over there. And then you have mentioned that how to give this vasopressin. Yes, as in the paracervical regions, which we are going and then we can control. But Deepak, you are an IVF specialist also. So you must be using that with your OPU needle. You are going inside on the base of that. This is one of the technique, but we have to see whether it is the location that we have see. Lateral is there, then take care of that. We should not go to or perforate the uterine vessels and all. So all precaution, all procedures which you are doing, you should be confident about that and then do. Yes. And secondly, the perforation, again, you have to think whether perforation has occurred with the seizures only. Then definitely the chances are less. But on the medical legal part, and to go and sleep comfortably, you put a scope. The only thing is that to infertility patient, we have to explain that we are putting for the benefit of you, and simultaneously the other procedure you can do, you can see tubes and all. So you counsel them in a positive way. We want to see just for your benefit. We are not hiding anything in front of that. We give the picture that by adding this laparoscopy, we have done the one another procedure, because the fluid you can see through the tubes and all, everything that can be done. So it's all with the patient safety is the first, and go with the methodical. Definitely these submucous fibroid, that limitations you have to see according to your expertise. You should not think कि देश दीपक 4 centimeter पूरा निकाल रहा है, यदि मैं इसको करूं, if I am comfortable with only the 2 centimeter, I go with that. Thank you. Thank you.
Thank you, Dr. Leela ma'am. Over to Dr. Monica for third case.
Our third case is a patient of 32 years old coming with a history of secondary infertility. She has a history of scanty menstruation with altered colored vaginal bleeding followed by amenorrhea, and there's a history of D&E done 1 year back for incomplete abortion. And now she had got amenorrhea for 5 months, and estrogen progesterone challenge test was negative. What we will see in the imaging ultrasound finding. Dr. Priya, please, will you take the case? Dr. Priya? Dr. Shailesh?
Yes, ma'am. Yes, ma'am. Priya ma'am, are you taking?
Yes, yes. In the imaging, we will see some adhesions. The echogenic irregular eccentric lines will be there in the endometrium with some hypoechoic and hyperechoic foci will be seen. We can go for saline hysterosalpingography also. This will also help us to know for the adhesions.
So, Dr. Priya,
Even
in
3D
this modern obstetric, you will always go for a saline infusion sonography or 3D ultrasound.
3D ultrasound, sir.
Right.
3D ultrasound is wonderful, sir, and it's almost 95% reliable sensitivity it has. And Asherman's is we want Asherman's patient to operate hysteroscopically. So I think this is Asherman's nowadays is very much because most of the patients from rural background are having D&E more often.
Even for a small RPOCs, they are going for the D&E.
Yeah.
Do you
Can I
consider
add something, sir?
Yes. Yes, ma'am.
Yeah. Can I add something?
Yes, ma'am. Yes, please.
Yeah. There's an excellent 4D ultrasound classification system which we follow whenever we are suspecting Asherman syndrome. It is a combination of Doppler studies with a transvaginal 3D, and in which you can grade it as grade 0, 1, and 2. Grade 0 is less than 1/3 of the cavity, 1/3 to 2/3, and more than 2/3 of the cavity. So you can actually elicit it, and hysteroscopically, it is very important for counseling the patient, not only for gradation. When we know that we have a grade 2 Asherman's, we are going to take a lot of time during the hysteroscopic adhesiolysis. We might have to keep a Foley's later. We might have to, so all this, so on and so forth, has to be counseled pre-operatively. And this classification is extremely good. If we start doing it for all Asherman syndrome, it, I think, improves the prognosis as well as the intraoperative planning of these kind of patients.
So,
right, Dr. Manjiri, you have 4D ultrasound expert. What about others who doesn't have a 4D? Do you consider SIS or HSG?
SIS also, SIS is equally good, sir. 6 number Foley's catheter you can insert into the cavity. 2 cc can be instilled into the bulb. Once it is stabilized, 5 ml of normal saline can be instilled, wait patiently for the entire cavity to be delineated, and then we can know whether it is less than 1/3, 1/3 to 2/3 cavity, or entire cavity is with adhesion. So saline infusion sonography is great, but considering the better alternatives, I think saline infusion sonography is time taking, and when you put a Foley's and everything, it comes with a pain factor, and your 3D, 4D is, I think, obviously any day is non-invasive and much better. Of course, it depends on what kind of a setting we are used to.
Deepak sir, what about hysteroscopy in the Asherman cases? Whether you will do it, Dr. Deepak sir,
Of course,
are you there?
hysteroscopy very important cases of the SMN should know, but I can say gynecoscopy. In all cases of the SMN, should the gynecoscopy start from the cervical canal. Sometimes we find the adhesion in the cervical canals also, and there is always stenosis at the level of internal os also. So use the very delicately and go very slow, and first follow the any black hole, and then first put the forceps and then open the forceps. So the saline will go inside the uterine cavity, and then automatically you will able to see the right path. So first palpate with the forceps, then introduce your scissor and cut the adhesions. So we should create a V-shaped cavity, and always the line mark is the internal os, and then both side the ostia. So, and sometimes adhesion is between the anterior uterine wall and posterior uterine wall. Sometimes there is a very dense adhesions. So even you can have tactile sensation, whether you are cutting the myometrium or you are cutting the adhesions also. So tactile sensation is also very important. So in these cases, we should be very meticulous and slow, so to prevent the perforation. So if you see any bleeding myometrium, you are able to know that you are reaching in the myometrium, there are more bleeding. Sometimes increase the pressure, sometimes reduce the pressure, and then see where is the bleeders. So these are the tips and tricks while doing the intrauterine adhesolysis, because in such cases, there is always chances of the false spaces also. You can enter in the false spaces.
Sir, will you put the laparoscope along with the hysteroscope?
Normally, in cases of the infertility, we are doing hysteroscopy, laparoscopy simultaneously, and we are using two endovision system in our center. And otherwise, you can use the sonography also, but normally we are using two audiovisual system. One team is seeing illumination sign and everything, whether we are in right way or not, like that. Sometimes we are doing PRP also in cases of the Asherman syndrome in our center. Having good result with PRP.
Sir, what is the logic for using laparoscopy if you are not going for the other method, other things to see? Because when the perforation will occur, you will definitely know, and after that you can put the scope.
Basically, sometimes if we cutting in wrong place, then you will see the illumination sign. You're getting my point? Yes. Here is the chances of you should prevent the perforation. Don't do the perforation. Our aim is the prevention. So for proper guidance, sometime पता चला कि posterior wall में ज़्यादा जा रहा है या cervix में मतलब एक proper guidance with laparoscopy you can get. That is the.
And we can diagnose many other things also if there are intrauterine adhesions also, because there's a chance of infection.
Intrauterine adhesions, sometimes uterus is totally covered by
adhesions can be there also.
Tuberculosis is very common in India. Na? Sometimes these adhesions are mainly called tuberculosis, or sometimes after DNC also.
Sir, if the patient is tubercular positive, even though you will do adhesiolysis in these patients?
How will you able to know that tuberculosis is positive? That patient with TB PCR, not confirmative. The diagnosis with hysteroscopy, laparoscopy only, you are confirmed that is having the tuberculosis. Then post-operative, we can start the ATT.
So after doing hysteroscopy, if we find adhesions, we do adhesiolysis or we give the ATT to the patient.
Even after doing adhesiolysis, we can start the ATT and a strong dose of the estrogen, progesterone, and we can keep the Foley's catheter for at least 2 to 3 weeks. These are the post-operative management of cases of the Asherman syndrome.
Dr. Deshdeepak, I'd like to intervene here.
Yes, sir.
There is no evidence that hysteroscopic adesolasis guided by external imaging techniques, maybe ultrasound or laparoscopy, prevents uterine perforation or improves clinical outcome. However, such approach used inappropriately selected patient may minimize the consequence of perforation. So it is not mandatory to put laparoscope every time if you are doing a Asherman's. Otherwise, the team of expert hysteroscopists will start blaming you that what is the need of putting a laparoscope. So level B evidence of guidelines of intrauterine Sinecane management of February 2012 says there is no need of putting laparoscope every time. But additionally, if you feel that you are not going to get that V-shaped cavity, you can put it, but it is not mandatory. And about the pediatric Foley's catheter, you said about 3 weeks time, right, sir? Hello?
Sometimes, sir, 1 week is also sufficient, depends upon this. I don't have any proper guidelines. What is the guidelines says you? Tell me.
Right. Pediatric Foley's catheter can be kept if there are severe Ashermans you have done. Secondly, it is going to help you for not forming adhesions again. Still, you can keep it for maximum 7 days after doing the hysteroscopic adhesiolysis. You can see how to put this intrauterine balloon by hysteroscopy.
You can cut the tip of the.
Right. You cut the tip. The use of an IUD stent or catheter reduces post-op adhesion formation. There is limited data regarding subsequent fertility outcomes. That is grade A evidence. And if an IUD is used post-operatively, it should be inert. Remove the copper and then you can. And there is no evidence to support refute the use of post-operative, intraoperative, or post-operative antibiotic therapy in surgical treatment of intrauterine adhesions. Now I'll go to Dr. Manjari. What dose of estradiol you are using for such patients after hysteroscopic resection?
Sorry, I'm starting with 2 milligram 3 times a day as a baseline, and then I can increase it as and when required. I also would want to place one thing that it's very common these days to find recurrence of adhesions after a very well done hysteroscopic adhesiolysis for Asherman's. So what I have started doing, it's not mentioned in the books, but then when I call the patient after the next period in the mid-cycle, I've started doing something like a, we can say it's a modification of a saline infusion sonography in which we put the embryo transfer catheter. We keep the patient mid-full bladder. We put the embryo transfer catheter and we instill 5 ml of saline with the help of a BD syringe that we use for embryo transfer, so that we can check whether there is any recurrence of the adhesions, because every time you can't post the patient for a hysteroscopy, and sometimes the 4D cannot really diagnose the flimsy adhesions which are again going to start, because we know that adhesion prevention is very difficult, especially after hysteroscopic adhesiolysis. So this in my practice has helped me, and it is very easy. It is available in our IVF centers.
You can publish that data, but ESG 2017 guidelines says recurrence is common 2 in 3 in severe intrauterine adhesions. Follow-up is mandatory, that is grade B evidence, and regardless of surgical intervention use, reassessment of uterine cavity, usually after 2 to 3 cycles after surgery, is worthwhile. Ambulatory method like office hysteroscopy, the way you use 4D ultrasound, we use office hysteroscopy. With a Caesar, you can cut those flimsy adhesions. Dr. Monica, ma'am.
Leela ma'am, you want to add some inputs in these?
Yeah, one thing is that the case which
Dr. Leela ma'am, just for one second. Dr.
Yes,
Charu, when are you going to go for a surrogacy in cases of hysteroscopic adhesiolysis? How many attempts you are going to do a Asherman surgery, and when you go for a surrogacy?
Yeah, surrogacy is difficult to do nowadays. So we'll try our best to do the original analysis. So as we all mentioned correctly that we have to do the who are the experts who can do this like flimsy additions. So sometimes they just like वो अपने आप ही खत्म हो जाते हैं pressure से, and if the fibrous tissues they
मैडम
are
हम बात कर रहे हैं कि आप कितने सर्जरी के अटेम्प्ट के बाद सरोगेसी एडवाइस करते हो?
I have not advised till now. Mostly cases are going to be correct, but if it is very like fibrous tissue and the recurrence is there, I think 2 to 3 attempts are maximum, not more than that.
Because the sir, why I'm telling you this, I have done a case third time, which was done 2 times outside, and this patient conceived spontaneously and had rupture uterus at 6 months. So one case, but from that point, I feel it's better to go for a surrogacy than doing overzealous correction where endometrial cavity is getting damaged. Dr. Shailesh Jain, what is your views?
Sir, surrogacy is already controversial nowadays.
It is not controversial. It is the land of the law. You have to follow the land of the law.
Yeah, but obviously, as we are following the land of the law, so I'll counsel the patient first. I'll counsel the patient in this case. Whatever is in your benefit, we'll prefer that.
Right. Dr. Leela Vyas, ma'am, your expert comments.
Yes. One thing is regarding that regionalizes or the Escherman you're expecting, the case which you have put, that is of the 6 months before the DNA has been done and now she is not having periods. In these types of, usually you see that actually Escherman, exact definition go, the Escherman comes at the level of internal loss. I think Deshdeepak has mentioned these things. In these types of the cases, once you enter with your hysteroscope and the Caesar with you, you just cut up and then see the cavity. So one thing is that, and another that can be the simple. So the history part is very important. If it is because of any surgical procedure or the repeated curettas and short history is there, definitely these to be treated very effectively. Then comes the history of the long infertility is there, and you suspecting that is the tubercular patients. These patients usually have a history of having taking 2-3 times ATT, and all these cases they are having this. If you enter into the uterine cavity, one thing is no guidelines you have already mentioned, no need of that other modalities to use laparoscope and all. Laparoscope aap jab karte ho, if you give the position downwards, definitely you are going to perforate the uterus. That is one thing is that associated with this, because otherwise you are not able to see the pelvis. So one thing is, yes, definitely guidelines are also not saying, practically if you see that, then you go into the matter that the thick, you were talking about the how many times you will proceed for the surgery, and the case which you have mentioned that after third surgery, the ruptured uterus, because you are not able to, these thick, aapka pehla surgery, aap pehle gaye, definitely we try, we take that consent, we are going to treat. Second time, we take our photographs and explain them. We will try a second time. If second time the same cavity is obliterated, don't attempt for the third time, because we are not going to do this. If in second time, that if you are able to create, means first time halfway you have cut all these, if you are able to cut and reach up to the fundus, definitely that gives us a good prognostic value. And that time, if you have planned for that PRP and inject subendometrial, endometrium is not created, you inject once, then start with your estrogens, and definitely for the progesterone halfway to for the withdrawal. If patient starts withdrawing, endometrium is thin, then again you can try for the subendometrial PRP injection. That gives a good results and the chances of the pregnancy. Yes, surrogacy, 2 attempts. If thick adhesions, try for the surrogacy rather than creating that which you have seen, that we don't want a ruptured uterus after the pregnancy, whether it is a 6 months or the 8 months or the 9 months. That trauma the patient can't tolerate. Thank you.
Thank you, ma'am. Thank you so much. Thank you, Dr. Deshdeepak, Dr. Manjari. Now we move on to the fourth case. So this lady presented with primary infertility for 3 years, history of infrequent coitus, imaging were suggestive of partial septum. How you do counseling, and should this septum resection to be done or not done. So I am not going to ask this question to Dr. Shailesh or Dr. Deshdeepak. This question is for the infertility specialist. Anybody can take, Dr. Manjiri or Dr. Dr. Priya, you can take this.
सर इजी वाला क्वेश्चन किसी और को दे दिया
किसी कोई भी ले सकता है, ठीक है, प्लीज। शैलेश, आप तो ऑपरेट करने वाले हो। आई एम आस्किंग यू दिस।
सर्जन को मत दो, सर्जन तो चाकू चलाएगा।
Dr. Manjiri, what is your views?
So basically, if we are suspecting a partial, like how on this patient, what imaging was done to suspect a partial septum?
3D ultrasound.
Okay, because in cases in which you have an established diagnosis which is there, it is prudent to go ahead and do a septum dissection, of course, using no energy as far as possible.
Her HSG is normal.
And
tubes are normal. Her tubes are normal on HSG.
That is still okay, because even if it is a partial septum, the implantation is going to be a problem. However, there are cases, so many cases in which during the C-section or something, you do find these kind of septa, and there are schools of thought who say that partial septum may not be removed, etc. But if you are asking me from IVF perspective, I will go ahead and do a septum and then only do an IVF. Later, if we don't do this, you have to sit and counsel. Why didn't we not remove? Patient takes 800 other opinions of doctors who say that अरे ये septum नहीं निकाला, इसकी वजह से fail हो गया. So it is always better, if you are asking me, that I would go ahead and do a hysteroscopic resection of the septum and then do a embryo transfer.
So as an expert ultrasonologist, 4D ultrasonologist, how many times you see this picture, which is seen as ASRM uterine septum move picture?
Correct. So basically, we do see it because it is the index of suspicion should be very high for diagnosing the Mullerian abnormalities. That is because they don't come on the face with you. You have to diagnose it. So the angle between the two cornu and in both the sections, you have to. Am I audible? I think some message is coming on.
Yes, you are audible, please.
Okay, so that is very important, and whether the leave us only not only the septum but the other parameters also have to be taken depending on what is the morphology on your 4D ultrasound. So if we are regularly doing a 4D ultrasound, there is a high chance. Of course, the distance between the endometrial fundus and the actual fundus will also tell us the expected nature of the septum, the thickness of that distance, etc. So everything has to be considered: the angle, the distance, and the suspected location.
Right. You need to differentiate between a bicornate uterus and septum. That is what 4D ultrasound is going to help you. So
Correct.
And what ASRM says about does a septum impact fertility? There is insufficient evidence to conclude that uterine septum is associated with infertility grade C. Infertility can be result of multiple factors. It is often difficult to determine if only septum is a positive cause, and mostly several other studies have indicated that hysteroscopic septum incision is associated with improved clinical pregnancy rates in women with infertility, that is grade C evidence. So Dr. Manjiri is 80% right. Does treating a septum improve obstetric outcomes? Yes, it is going to improve the outcome of live birth rate. So now coming to Dr. Bansi, my good friend, which is the most suitable instrument for hysteroscopic septoplasty? How do you decide your endpoint?
Sir, Bansi, sir.
Hello. Yeah, Kalyan, I am back. Thank you. Actually, the thickness of the septum is important in deciding the instrument for the resection of septum. But most of the time, I will do it with the scissors. And when both of the ostia you are able to see, that will be the end point, and I will do less of septoplasty. I will not go to do it completely.
Over correction, you won't do it.
So I will do under correction actually. And scissor is the best instrument to do it actually.
Right. So anybody wants to add something about the surgical technique? Dr. Shailesh?
No, sir, everything, I think everything has been discussed.
So no. When you want to use a monopolar cauterization and seizure, like complete septum, thick septum, what are your views about this?
So depends actually. There is already a very much debate on whether to excise or incise. So I think it's to individualize. If it's a thick septum, you can excise. Although we prefer incision. And in monopolar also nowadays bipolar cautery is there, sir. So better to deal with bipolar saline, insaline cautery we are using.
Dr. Deshdeepak, how do you manage complete septum?
Complete septum can be managed in two ways. Suppose it is complete, say for cervical septum also, then we do one cavity, we put a pediatric Foley's catheter, and then I start from the above. You're getting my point? And the landmark is the ostia. So then we enter to the another cavity in the midway, and then we can complete it cranially and caudally in both the directions.
So rightly said, you put a pediatric Foley's in opposite cavity and start from the other end, and you start midway, so that once you see that balloon, pediatric balloon catheter, that is a point, then you have entered into the other cavity, then cranially and caudally, you can do the procedure. It is always better to do it with some monopolar or bipolar cauterization, because it is going to cut the tissues fast and your surgery can be finished faster. What is the role of estradiol after doing the septum resection? Dr. Deshdeepak sir.
So, we normally give a high dose of the estradiol after doing the resection for a period of the 28 days, and followed by progesterone also. So at least for 3 cycles, we give high dose of the estrogen and progesterone.
Yes, sir. We also prefer estrogen for 30 days and last 10 days progesterone. And very good results.
So for 1 cycle or 2 cycles?
50 days estrogen plus 10 cycle, 10 days progesterone, 1 cycle is enough in most of the cases. Yes.
So when you are going to tell her to have pregnancy after this?
Normally, I tell them after 2 months. Sir.
Yes, sir.
Right.
Same.
Right. Dr. Leela Vyas, ma'am, your expert comments.
Yeah, everything has been covered. But one thing, sometimes we have to see that complete vaginal septum. One case I just came across that. One is complete vaginal septum. There were the 2 cervix on both the sides. 2 cervix, I thought uterus diatalphys may be there. The patient has been started with that, put the laparoscope. There was a single dome. Hence, there was a no 2 uterus was there. So uterus was single. So then 2 cervix are definitely on that. One cavity was smaller, another cavity was same. I started with that up to the septum, vaginal septum I cut. Then I saw the 2 cervix, and those 2 cervix have their own this. So histoscope passed on both the sides. So these are the things which anomalies which we are facing, that it is not that complete septum. I think this procedure I have abandoned. I just want from you all that this expert opinion, because I stop there, because if we cut a cervix, because the 2 well-formed cervix, if we cut it, that this incompetence will be not able to treat. And the right cavity was bigger, left was less, all one dome, right tube was patent, left was also, because from both the DAC, we have done the perturbation. Now the patient conceived, and then she is having on the right side the pregnancy. So some anomalies. So my suggestion is that if you are starting with these anomalies, it's not necessary which book has mentioned. That's why our classification has been changed. That it's not always that. Where the process has been stopped, where it has been means just stopped, and now we are getting a different types of anomalies. You have already said, Deshdeepak said that if it is a 1 cavity, means only single cervix, complete that we have to avoid these complications, not to go with the overcorrection and all these things already mentioned. And definitely thick septum is the energy source required, and estrogen progesterone definitely work very nicely. So one thing is that the pre-operative assessment is very important. Don't take it guaranteed कि वो जैसा book में लिखा वो आएगा. There is some variations are there. and which we are, as many cases we have seen that we found that these are types of the variations are there.
Thank you so much, Dr. Leela ma'am. Dr. Deshdeepak sir.
Sir, I have encountered 4 cases of the OVR, also oblique vaginal septum, that we can cut with the resectoscope, and 2 cases of the robot also. These are the oblique septum. So in these cases, sometimes laparoscopic guidance is very safe and our sonography guidance. In cases of the robot uterus and oblique vaginal septum, that is OVR syndrome.
Very rightly said. Now, last 5 minutes, Dr. Monica ma'am, next case, please.
This is the patient. We're having the primary infertility for 6 years. Except for the ultrasound report, everything was normal. Ultrasound showing 5 into 4 centimeter well-defined solid mass with a whorled appearance in the intramural part. What is your diagnosis and management? Priya ma'am, please.
Dr.
I
Priya.
would like a diagnostic hysterolaparoscopy for her. And if the cavity is normal, then we can give her ovulation induction and try for IUI.
Dr. Shailesh, any other opinion?
No, ma'am, same.
Dr. Shailesh, what Dr. Monica wants you to answer for the tips of myomectomy.
Tips of myomectomy. Let's start with the vasopressin first. The dose is standard dose is 20 units in 200 ml. We all are using. Sometimes when vasopressin is not available, we can use saline. Then the position is very important. Size is not important. Yesterday we removed 10 by 10 centimeter, but it was simple subserosal, so nothing to do. So position is very important. If it's broad ligament, if it's cervical, then you decide the incision. And if you are a ipsilateral surgeon, you are not contralateral, so suturing is very important. So you have to decide the incision. Most people are saying it's better to give tangential incision, that is oblique. So the suturing is easier, or transverse incision in cases. And it depends that sometimes some people say that you have to give 2 incisions for 2 fibroids, but better to give single incision. And the approach for the myoma should be easily accessible, and then suturing is very important in such cases. Now, the importance of suturing, the barb sutures. The barb sutures you can use, but I personally prefer that I am from the old school, so I prefer normal Vicryl, and baseball suturing is very important. So baseball suturing, if hemostasis is achieved by baseball, then baseball, and if it's by simple interrupted sutures, you can stitch in 2 layers or 3 layers. The end point should be that hemostasis should be achieved. The final thing about any tissues that are prevention, that are adhesion barriers, or that we can put so that the raw surface is not there. So I usually don't believe in such adhesion barriers. I think these are more of psychological benefit. So if your hemostasis is good, and if you don't leave any raw area open, then and opposition is perfect, then your surgery will be wonderful. Any other thing you would like to discuss? So in myomectomy also, we counsel the patient first that when you have to return, what are the follow-ups. I believe in 3 or 4 follow-ups till 6 months. I say that you come once after 7 days, then after 1 month, then 3 months, and 3 months I'll be having a ultrasound for recurrence or any other problems. And after 6 months, when we say after 3 months you can conceive, so we plan for your fertility. So
what about the morcellation part, Dr. Shailesh?
Morcellation, again, sir, you ask controversial questions to me. But yeah, morcellation is very important. Nowadays, we are removing in bag also, and per se without bag also. But what the guidelines say that at present you have to remove it in bag. And the morcellation, depends actually what instrument you are using. Simple, we have Indian oscillators also, and we have other oscillators also. I suggest that during oscillation, one important thing is there are 12 mm and there are 15 mm oscillators, and 10 mm or 10 centimeter also, 10 mm also. So better to you have to check what is the airflow inside, and what is the pneumoperitoneum, what is the pressure inside while removing these. This is very important. Sometimes whenever you put your this oscillator inside, the air goes out, and these are the chances when you can injure the viscera. So this is very important during oscillation. Otherwise, the rotational power, rotating power depends on every instrument, on every brand, that what is in 1500 RPM or 1000 RPM, 1200 RPM. So it depends.
Very rightly said. And Dr. Shailesh, you have covered almost all points. Now, as scarcity of time, we have already crossed 1 hour, 10 minutes. I would like to thank all the panelists, that is Dr. Shailesh, Dr. Manjari, Dr. Bansi, Dr. Charu, and Dr. Deep sir, and my wonderful Dr. Deep and Dr. Priya Kadam, and my wonderful co-moderator, Dr. Monica Gupta. I'm thankful to everyone for active participation in this. And I'm really thankful to Dr. Priyankur and Dr. Monica Umbadars for this opportunity. Dr. Dabde sir, final comments? Because our expert is not seen. Dr. Leela Vyas ma'am has come. Dr. Leela Vyas ma'am, please. Panel, yeah. Myomectomy.
Firstly, the congratulations. You always make these panels very in a perfect way. I think we are the co-moderators always. Next time when we are coming physically, I don't know. In next conference we'll come again. So you are the expert in handling these panels, and very nicely selected cases and all basics. I think that all the audience got benefited by these discussions, and which all also with the evidence based also, and somehow the experiences as the Manisha and all they have shared there. So always we say the medicine is go with the evidence, which EBM we call it as it is the evidence based, and also the experience based also. So thank you very much for conducting this, and I think go for the another panel in next few days regarding these.
Thank you. Dr. Monica Gupta, please concluding remarks, please.
Monica ma'am.
Unmute ma'am. We are eager to listen to Dr. Parikshit Tank.
Monica ma'am, please unmute yourself. Yes,
we tried to discover all the topics, but unfortunately, because of lack of time, and it was a very nice discussion with the panel and with the our experts and Dr. Kalyan. Hopefully, we will have another chance to discuss more.
Thank you and welcome, Dr. Parikshit Tank.
Thank you, Kalyan sir. Thank you, Monica ma'am. That was indeed a very detailed discussion on fertility, on endoscopic surgery enhancing fertility. We'll move on to the next panel. Can we have the slide, Omkar? Yeah, our next panel is on optimizing the treatment, optimizing the successes of IUI
Omkar,
and
the next slide, please. Yeah,
yes.
This time.
Yeah. So the next panel is on optimizing outcome of fertility treatment. It will be moderated by Dr. Parikshit sir and myself. And our expert for this panel is Dr. Kamini Patel ma'am. Can we have the slide? Yeah. Dr. Parikshit Tank, we all know, is a consultant at Ashwini Maternity and Surgical Hospital and Center for Endoscopy and Assisted Reproduction at Mumbai. Also at Jupiter Hospital, Thane. He is the honorary professor of Pacific Medical College.
You don't have to read all this. Just
yes, sir.
You don't have too much time. No?
Okay, sir. Okay. So we'll welcome, sir. Welcome, sir. I'm looking forward to moderating the panel with you. Actually, welcome. Yes. Next, can we have Dr. Kamini Patel slide, please? Yeah, skip this. Yeah. Dr. Kamini Patel, ma'am, is the founder and director at Vani IVF Center at Maninagar, Ahmedabad. She has been the president of various organizations and currently is the president of AOGS and SOGOG and a senior consultant gynecologist and infertility specialist at Care and Cure Hospital. Welcome, ma'am. We have an elaborate list of esteemed panelists today for this panel. Our first panelist is Dr. Shrutika Thakkar. Can we have the slide, Omkar? Yeah, Dr. Shrutika Thakkar is the medical director at Medansh Multi-Speciality Hospital and IVF Center in Mumbai. Also working as a consultant at Fortis Jupiter and is the managing council member of Maharashtra State Chapter for ISAR. Welcome, Dr. Shrutika. Our next panelist is Dr. Chaitanya Shembekar. Dr. Chaitanya has passed his MD from Government Medical College, Nagpur. He has a fellow in endoscopy from Germany. He's received various awards and he is currently he was the organizing secretary of the Yuva Fogsi 2019 and he's written various books. Thank you. Welcome, Dr. Chaitanya.
Thank you.
Our next panelist is, of course, Dr. Rohan Palshetkar. He is the head of unit at Bloom IVF at DY Patil. He is the national coordinator of the Young Talent Promotion Committee, second joint secretary of AMOG and the joint director of MED. Welcome, Dr. Rohan. It was a wonderful lecture by you in the beginning of our session today. Welcome, Dr. Rohan.
Thank you, ma'am.
Our next panelist is Dr. Rajiv Dabde. Dr. Rajiv is a director at Navjeevan Fertility. He is the assistant professor in the Department of OBGY at Ashwini Rural Medical College, Kumbhari, Solapur. He's presented various research papers. Welcome, Dr. Rajiv, sir. Yes. Can we have the next slide, Omkar? Hello?
Can you see the slides? Dr. Darshan?
Yes, we can see the slides. We have Dr. Darshan Sureja. Yes, I can see him too.
Yes.
Good evening. Shatabdi,
I think there is a network issue at the Shatabdi, ma'am.
yeah. Dr. Darshan Sureja, ma'am. Sureja sir has a diploma in endoscopy and he's specialized in training in IVF from Singapore and he's the director of Global IVF Center. We welcome you, sir. Can we have the next slide, please?
Thank you, ma'am.
Our next panelist is Dr. Kajal Mangukia. She's an IVF consultant at Orchid Fertility Center, Surat. She's a medical director at the same, and she has been running 3 successful centers in the last 15 years in Surat, and is specialized in handling high-risk pregnancies. She also has many academic accolades to her credit. We welcome you, Kajal.
Thank you.
Our next panelist is Dr. Nidhi Varasani. She holds a fellowship in reproductive medicine from CMC Vellore. She is also a fellow of the Indian College of Obstetrician and Gynecologist, being the director and IVF consultant at Sahaj Gastro Care and Surgeon Fertility Center at Bhavnagar, Gujarat. She has 2 national and 1 international publications to her credit. We welcome you, ma'am.
Thank you.
Our next panelist is Dr. Monica Singh, ma'am. She has been awarded with 10 gold medalists and she is the professor at Ellen Medical College, Bhopal. She's also a consultant at reproductive medicine at Bhopal Fertility and Endoscopy Center. She has been the honorary secretary at the MT chapter ISAR 23-24 and the vice president of Bhopal OBGY Society of the current year. We welcome you, ma'am. Shatabdi, are you there?
Yes, I'm there. I've kept my video off so that I can.
Yes. Omkar, can you please share the slides?
Now it is visible?
Yes.
Yeah. So we are having 4 cases for discussion today. So we'll just begin with the case number 1. Case number 1, yeah, please go on. The case number 1. Yeah, a case number 1 is a 32-year-old couple has been keen to conceive in the last 2 years. The man has normal semen parameters, and for the female side, she has normal examination, hormone test, and pelvic ultrasound. Next slide, please, Omkar. Yeah. So we want to discuss, are IUIs worthwhile? Would IUI be a benefit in this couple? And would you mandatorily do tubal testing before initiating a trial of IUI for this couple? Dr. Shrutika, if you would like to take that, please.
So IUI definitely would benefit a couple who is trying to conceive since last 2 years. So basically the principle of IUI, as we all know, is placing the sperms at the right place at the right time. And often couples fail in doing that. And that is why IUI would be useful definitely. With regards to mandatory tubal testing, most of the guidelines will insist on doing tubal testing. How much we are able to initiate that before one IUI is difficult. So although we would mention it on paper, but if the couple refuses to get tubal patency test, honestly, practically, I would still go ahead. But yes, we should always confirm patency of tube before starting an IUI cycle.
Absolutely. So yes, according to a recent study, or not a recent study, but according to one of the papers in fertility sterility also, this case seems to be like a one with unexplained infertility. So for unexplained infertility, 6 to 7 cycles of IUI is worth doing 6 to 7 cycles of IUI before proceeding on to the next one. So yes, IUI would be of benefit in this couple. Next slide, please. Yes. So IUI versus intercourse, as we discussed, in unstimulated cycles of couples with unexplained infertility, there has been only one RCT. We are discussing the unstimulated cycles. Pregnancy rates in IUI have been 4.1%, whether in normal intercourse has been 2.4%. These are this discusses unstimulated cycles. Next slide, please. So little evidence to assess IUI is in unstimulated cycles. So we move on to the next set of questions. What are the clinical situations where you recommend IUI? Are there any non-medical indications of IUI that we can think of? And in which couple would we consider IUI to be contraindicated? If anyone who wants to take it, please, it's open to all.
Shall I take, madam?
Yes, please. Yes, please, ma'am. Yes.
So the other indications for IUI, one we already discussed, that is the unexplained infertility. In patients with mild to moderate endometriosis also, and in cases of male infertility when the total count is less than 10 million. So these are the other indication. And non-medical indication for IUI is maybe the the sonosalpingography. I'm not sure, but for the second one, and in which couple would we consider IUI contraindicated? So in couple when the bilateral fallopian tubes are blocked, these are the cases IUI should be contraindicated.
I think the non-medical conditions, what probably Dr. Shatabdi means is when the husband is away, say when he's overseas,
Yes.
or if you frozen sperm and you would like to do it for social reasons.
Also, yes, also for a non-married woman or a
Yes.
widow woman, where we can go ahead with donor IUI. So
Yeah.
that could be one of the medical indications of IUI. Yes, rightly said, ma'am. Next slide, please.
Dr. Chaitanya wants to.
Yeah, I just wanted to add one thing. Since we are discussing unexplained infertility, there are clear-cut guidelines for unexplained infertility, which clearly state that any patient who is having normal semanalysis, normal ovulation with at least one patent tube should be labeled as unexplained infertility if they are still having difficulty in conception. And in that situation, after a brief period of maybe counseling, the first step that you have to do is to go for IUI. And that is what guidelines say. So the first thing you have to do is go for IUI in unexplained infertility. And that IUI should not be unstimulated. Of course, there is no point in doing unstimulated IUIs. But in unexplained infertilities, the strong evidence goes in support of clomiphene citrate or nowadays letrozole, which is becoming popular, along with IUI. Not only this, they have also said that gonadotropins should be avoided because they are not only concerned with the results, but they are also concerned with the side effects of the IUI, which include hyperstimulation and the multiple pregnancies.
Yes, multiple pregnancies.
To avoid this,
Yes.
they have said that gonadotropin should be avoided, but otherwise, the first line of treatment goes in favor of IUI in unexplained infertility. But only is one point I would like to add here is nowadays the number of IUI cycles which we do is going down because initially it was 6, and now I think nobody is doing more than 4 IUI. If the age is more and the duration of marriage is more, then maybe at 2 or at the most 3 IUI. So number of IUI should not be 6 or 7. It should not be more than 4 in any case.
Yes, yes, rightly said. Next slide, please, Omkar. Very nicely explained by Dr. Chaitanya. Yes, as we discussed, unexplained infertility, male factor, mild to moderate, we know. Minimal or mild endometriosis, we can go ahead with IUI. Next slide, Omkar. Exclusion criteria, as we all know, is bilateral block tubes, semen count, rather the total motile sperm count less than 6 to 7 million. We will not go ahead with an IUI and we'll think of other methods of treatment. Next slide, please. There are no contraindications as such. If there is no medical risk, we have to only rather a sense of ethics. I mean, what we mean by this slide is that we need to discuss case to case basis. There is no absolute contraindication as such other than blocked tubes and poor semen, but we need to decide what can be the prognosis and accordingly proceed decide whether the couple requires an IUI or not. Next slide, please. Yes, we will move on to the next case. Yes, case 2 is a 30-year-old woman who has amenorrhea unless administered progesterone. Her BMI is 29. Her sonography shows polycystic ovarian morphology, as we can see in the picture. Her husband has normal semen parameters. They have been trying to conceive since 3 years, and previous history includes 1 anovulatory cycle of clomiphene 50 mg and 2 ovulatory cycles of letrozole with 5 mg of
I think Satabdi probably is traveling and she has a bit of a connection issue. Satabdi, can you hear me?
Sir, I can hear you, but actually I'm traveling. Yes, so I'm not able to see the next slide. Sir, you please carry on, sir. Whenever I'm there, I'll chip in.
Okay, no problem. Sure. So actually, it's just the first slide going on. So please continue.
Yes, sir. So in this case, what overall health interventions would we like to discuss with the couple at this stage? What are the practical tips for this woman regarding lifestyle? What metabolic parameters are of interest, and what time frame do we expect to wait to optimize her BMI? Anyone can just discuss what overall health interventions would we like to discuss with the couple at this stage. Dr. Rohan, if you can take that.
So ideally, obviously, this is a case of PCOS. As we can see, she's having anovulatory cycles and her BMI is 29. So ideally, we want to start beginning with lifestyle management. In simple terms, we want her to reduce her BMI and reduce the weight. So ideally, yes, it always seems easier to counsel these patients that lose weight, you can get pregnant naturally. But what we need to do is we need to have regular follow-ups with these patients, counsel them regarding the lifestyle management, if required, even rope in a dietitian in order to give them a more balanced diet, or this. None of the fad diets should be used, such as your keto, your intermittent fasting, etc. They require a balanced diet and at least a minimum of 45 minutes of exercise per day. This would help them improve the insulin resistance and help the patient ovulate as well. These are a few things that should be done. Of course, adding on any adjuvants would be up to each person. I think metformin, your ionositols, melatonin, these are different adjuvants that can be added to this patient.
Do you use these adjuvants regularly, Dr. Rohan? What is your personal opinion on that?
If I look at this patient specifically with a high BMI and this, yes, I would use all these adjuvants in this patient specifically. When I'm looking also at the time frame, yes, we all say that we look at about 3 months of 3 months of treatment prior. So what I would advise to this patient is maybe we do, along with the lifestyle management and the adjuvants, we plan OI with PR for the first 3 months and then maybe shift over to IUI cycles, because she has been trying to conceive since 3 years. In those 3 months, if we do weekly follow-ups for the BMI check, it would encourage the patient and hold the patient even responsible that, okay, someone's keeping a check on me, would help them reduce the weight and possibly even ovulate and conceive naturally if the weight reduction is good in these patients.
Rohan, next slide, Omkar. Yes, so as we discussed, that we have to address the patient holistically. We have to explain her the entire health scenario. We have to assess her health holistically. We have to check her sugars, BP, rightly said by Dr. Rohan. We have to check about her diet and activity, sleep apnea. What we tend to forget, but we nowadays, we also give a lot of importance to the mental health of the patient, because this female is definitely with a BMI of 29, she's going to be on the obese side. So she might have body image issues, she might have some eating disorders, and these body image issues and eating disorders may lead to depression as well. So we have to also consider that part of her health and take care of the mental health as well, in accordance with the other metabolic and other daily activity improving, lifestyle improvement. Next slide, Omkar. As per the HRI guidelines of 2018, we have to look at it says to be very smart in our treatment or in our approach to a patient with polycystic ovarian morphology. We have to be specific, it has to be measurable, achievable, realistic, of course, and timely. We cannot give her unrealistic goals. 5 to 10% of weight loss is what we are looking at, with some healthy behavioral strategies. There is no PCIS diet as such, but a sustained calorie deficit would be good for her weight loss. So around 150 minutes per week of moderate intensity exercise is very much advisable to such females. Next slide, please. So we have to keep in mind that we should not give any unachievable or unrealistic goals to the female. We have to be very, very realistic in whatever we advise her. And around 5 to 10% weight loss is absolutely fine. Next slide. So metabolic parameters we discussed. See, biochemical parameters are not better than BMI. Of course, BMI is a much better, it has a much better predictable value when it comes to fertility outcomes. However, we might, anovulation was most closely related to the insulin resistance, and an
I would just like to add one thing here before Satabdi says something, that there are some patients who avoid going to doctors because they say that anywhere you go, the doctor will say, "Jao wajan kam karke aao." So, as rightly said, it is the smart approach which is important, and only 5 to 10% of weight reduction, that too in the over the 3 to 6 months. So you should tell them that, because they know their problem, but they cannot come out of this vicious circle because there are so many other factors. So, as rightly said, it is the smart approach which is important.
Absolutely. So now she has lost some weight. Her periods are irregular but spontaneous. 6 months have passed. Her AMH is 5.1. Would you prescribe non-ovulagents or adjuvants to her right now? If yes, which one would be the drug of choice? And what are the fertility care options that you will discuss with her at this stage? Yes, anyone can take this. It's open to all.
Ma'am, can I take that one?
Yes, please. Yes, please, ma'am.
Yeah, so definitely we would like to discuss fertility care options as well as adjuvants at this point of time, because she's been trying previously for 3 years, then 6 months have passed, so it's been 3.5 years already. So if she's tried with 2 cycles of letrozole, at the most we'll give her 1 more cycle or 2 more cycles, but then we'll proceed with IUI definitely. I would put laparoscopic ovarian drilling later, because the criteria say that patients, this particular subgroup of patients will not do very well with LOD. And plus, if it is approachable, she can reach the hospital, come for regular follow-ups, then gonadotrophins and IUI would be a better option. And for adjuvants, we would definitely prescribe metformin, as Dr. Rohan has rightly mentioned, and myoinositol can be added depending on case-to-case basis. And coming to pros and cons of gonadotrophins versus LOD, gonadotrophins have an edge that the fertility rates are good. The main disadvantages here is it is a recurring cost. So if the patient doesn't conceive in the first cycle, we again have to repeat it. Second thing, we are more worried about multiple pregnancies and OHSS in this subgroup of patients. So our titration of dose and the cycle we follow for gonadotrophins has to be very specific, and we need to monitor them very tightly and counsel them well, because mostly we go with the step-up approach and we prolong the doses for quite some time. So they have to be counseled well. Laparoscopic ovarian drilling, it has all the disadvantages that any surgery would have along with the anesthesia. And there is a chance that there could be adhesions, pelvic adhesions in the future. And ultimately, it's a surgery. So we would put it on the backbench, except that the patient is from a village, is not able to travel regularly, or is not affording for gonadotrophins.
I think BMI is an important factor which is to be kept in mind in this case, because she is not a lean and thin PCO, she is a obese PCO. So here again, laparoscopy would be the second choice, because there is, as you rightly said, surgical risk which is always there, and the lean thin patients, they respond best to laparoscopy.
That is what I said. This subgroup of patients, LOD will not work.
Yes, it may not work.
Also,
So
I just
what
wanted
is
to
the opinion of the rest of the house on LOD, on the laparoscopic ovarian drilling? Anyone has any differing opinion on that?
No, it should be the third line of management after trying oral ovulogens and maybe gonadotropins. In oral ovulogens, since she's got 5 milligrams and not ovulated, we can sometimes consider stepping it up to 7.5 or even using an extended letrozole regimen for her.
Yes. And if you go to, as per the algorithm says that before going for the next step, that is gonadotropins or LOD, and when the patient is CC resistant, the next step is to go for metformin. So metformin is in between the CC or letrozole and LOD or gonadotropin. So in between that, metformin is worth trying.
Yes, rightly said. Yes. So,
In combination.
as of now, we are preferring ovulogens, we are preferring gonadotropins, but we are keeping the laparoscopic ovarian drilling at the back seat, not at the front seat as of now. Yes. Thank you all. Next slide, please, Omkar. And as we discussed, that which women are most likely to benefit from LOD are the lean PCO ones, as just discussed. Yes. So metformin versus placebo, we have various trials, metformin versus clomiphene and metformin versus CC. So next slide, please. We know about metformin. Next slide. Yeah. So again, as per the ESHRE 2018 PCO guidelines, metformin in addition to lifestyle could be recommended in adult women with PCOS for the treatment of weight, hormonal and metabolic outcomes. So that has quite a good evidence. So as per the controlled ovarian stimulation guidelines by ESHRE given in 2019, it is strongly suggestive that routine use of adjuvant metformin before and or during ovarian stimulation is not recommended. So the COS guideline of 2019 strongly does not recommend the use of adjuvant metformin with the GnRH antagonist protocol for women with PCOS. So if you are going for IVF, ESHRE says not to go for metformin. There's a strong evidence for that. Next slide, please. Metformin is not needed for reducing OHSS risk in an antagonist protocol. The beneficial impact on obesity, So again, we discussed LOD and fertility in comparison to gonadotropin therapy. There was no difference in the live birth rate over 6 months. Advantages of PCO drilling, multiple pregnancies, chances of multiple pregnancies were significantly lower. Concerns with PCO drilling, as ma'am just discussed, and we all discussed that operative morbidity, like any other surgery, it will have its morbidity associated with the operation. There will be chances of increased adhesions probably, and long-term ovarian function. The impact on long-term ovarian function we still don't know. It might have a reduced long-term ovarian function with laparoscopic ovarian drilling. So right now it's on the back seat. Yeah, so case 2.3. Now this patient, female, has opted to undergo gonadotropin and IUI therapy and presents to us on the day 2 of her period. So would our approach be to use gonadotropins be different for her as compared to any woman who does not have PCO? And what trigger would you routinely use for PCO women undergoing gonadotropin ovulation induction? Anyone can take it, please.
Yes.
So,
Can you take the question?
Yes, please, sir, go
Yes,
ahead.
yes. For PCOS, if she has opted for, or if it is needed to add gonadotropins, we would expect to start with chronic low dose step-up protocols. I prefer to use first letrozole followed by addition of gonadotropins, which would help to avoid the OHSS. And for trigger, we can use, if follicles are number of the follicles are less than 3, then we can go for HCG trigger 10,000. The choice of the gonadotropins should not be different from the routine woman, but if recombinant FSH we use, so that would be more better on practical aspect. The studies doesn't show it. Studies says that any gonadotropins, either HMG is fine for PCOS also.
If I may add, Satabdi.
Yes, yes, ma'am. Please, ma'am.
So see, whether HMG you take or FSH we take, it depends. Whenever we are stimulating a PCOS, we should always have OHSS at the back of our mind. You should use the least possible dosage of whichever gonadotropin you are comfortable with. You should always have OHSS at the back of the mind. That means that you should always have maybe an IVF center in case the patient goes into OHSS. You should have the possibility of offering this patient rescue IVF. So that is something that you need to keep in mind. This is the case for IUI. So honestly, if the number of follicles are more than 3, we should not trigger at all. With regards to HCG or recombinant HCG, both would be similarly efficacious. So I would not be very concerned if you are using a good urinary product. I think that will be just as effective.
Yeah. Shall I add one point, Satabdi?
Yes, yes, Dr.
Actually, since we are discussing the protocols, we all discuss, this is a panel discussion, and here we are sharing our experiences. So we all discuss about chronic low-dose taper protocol, where we start with 37.5 and then give it for 14 days. And then we see the follicles, and then again, incremental dose of only half ampule, and that too again for 7 days. That may go up to 28 days. But I just want to know how many of us do really go for chronic low-dose taper protocol. Do we have such so much of patience, or we just modify it as per our Indian Jugadu protocol, where we can't wait for such a long time, but at the same time we are concerned with OHSS and we take care of OHSS as well? Because chronic low-dose taper protocol is something which is described in all the textbooks, but I have not seen anybody using it as far as our clinical practice is concerned.
Definitely, Sarji. One of the Jugadu protocol which I have done in last 2 months in few patients, they were not responding to even short doses of gonadotropins. Adding letrozole followed by on 8th or 9th, 10th day HCG 150 IU, and 2 of them patient conceived also. There were no follicular development even on gonadotropin stimulation, and we were worried about OHSS if we increase the dose. But adding HCG 150 IU for 3 days, we got the result. This is the one of the Jugad protocol.
Anyone else in the panel does something different? Please share with us.
37.5 is a really low dose, and sometimes it is quite an extended therapy, and both the patient and the doctor both lose patience. So we usually start with 75 IU, and definitely, as Dr. Shrutika has mentioned, OHSS has to be kept at the back of the mind, and rescue IVF has to be offered as and when required. But starting with 37.5 is really, really difficult in the current scenario, because if you keep on doing that for 28 days, the patient is definitely going to change the doctor.
In addition, sometimes we can even consider using high-dose letrozole to up to 7.5 and even 10 milligrams, where some of these patients have ovulated even without the use of gonadotropins.
Yes.
And as said by everyone, for gonadotropins, we have to counsel the patient prior that there's a risk of cancel circulation or conversion to IVF.
Exactly.
The extended letrozole works very well. I have also, as a share personally, I have been using it for quite some time now, past year or so. Letrozole 5 mg for 10 days works pretty well, and I have seen that the usage of gonadotropin in these patients have reduced a lot. So that is a really interesting thing which we can work upon and study in future. Yeah, thank you all.
Just one addition to the Jugaad, as Chaitanya sir said. I generally would start with 5 mg for 5 days, do a scan. If there's no follicular growth, then for the next 5 days, step it up to 7.5.
7.5, yes. Yes, absolutely. Rightly said, Dr. Rohan. Yeah, next slide, please. So on day 8 of stimulation now, we do a scan and we see that there are 3 follicles of 15 mm in each ovary. What do we do next? What is the, yes, Dr. Rohan, what do we do next if there are 3 follicles of 15 mm in each ovary?
In each ovary. So that means we have a total of 6 follicles.
6, yes.
One, definitely not go for an IUI because we've obviously hyperstimulated the patient. As I said, we have to now discuss with them regarding either cancellation of the cycle or conversion to an IVF cycle. As Shrutika said, that if you don't have your own IVF center, then have a tie-up with an IVF center if you're using gonadotropins. You will have to now discuss with the patient and see if they're willing to at least go for a pickup. It could become a sort of fertility preservation if they want, and if they don't want to go with an embryo transfer, or basically is either cancel or convert to an IVF.
Okay. So we discussed all this. We discussed the choice of gonadotropins and all. We'll skip this slide. Next slide, please. So when would we stop? If we have a total of 3, we would still continue with an IUI. What do you do? What does the panel do if there are 3 follicles of 15 mm each?
3 is my cutoff, not 3 in each side, 3 in total.
Yeah. 3 in total is good for us to go ahead with an IUI. Yeah. So trigger we have discussed. Yeah. Next slide, please. Now, next slide, Omkar. Yes. Trigger we have discussed. More than 4 follicles in IUI, cancel the cycle as we just discussed, advise abstinence. Okay, so what is the opinion of the panel on aspiration of the excess follicles? Does anyone do that? Leaving 2 to 3 and continue as an IUI cycle?
We have never done this.
If you're doing that, might as well
Important
take
thing
them
here
up
is
for
the
a pickup.
counseling regarding the abstinence. That is very important.
Very, very important. Yes, yes. Yes, next slide, please. So, in short, the factors affecting the IUI success rates, we discussed: female age, the endometrial thickness, semen parameters, the timing of the IUI stimulation method. All this will have more or less role on the success of the IUI. Next slide, please. Yeah, I will hand it over to Dr. Parikshit sir now for carrying over the next 2 cases. Thank you all for bearing with me with the unstable network. Yeah, over to you, Parikshit sir.
Okay, so thanks, Satabdi, and really you've set the ball rolling with those initial questions. We have Dr. Kamini Patel also with us, and it would be great to have her inputs before we move forward.
Is Parikshit sir's screen frozen?
Yeah, even I was wondering if my internet was down. I think it's a moderator's curse sort of thing today.
Looks like that.
Satabdi, can you please carry on? Sir will join back in a minute's time.
Yeah.
I think Satabdi has also lost her
Then
net.
I will only start Rohan, sir, just a second.
Rohan, you can take over.
Yeah. A 33-year-old woman.
Hi. Sorry. Clearly sorry.
Yes.
I don't know what's it with moderators and internet connections today. But I was just going to thank Monica for giving me this wonderful set of panelists whom I have to really only prompt very gently so that they give all the right answers. So now let's look at this 33-year-old woman and her husband. They are in your consulting room, 5 years trying time. The man has normal semen and they have an HSG from somewhere else, and that's what you can see on your screen. They've been advised to go ahead with an IVF cycle this month. So let me ask Dr. Dabade a few questions now to really set the tone for this case. Can I have the next slide, please? So, sir, is there anything other than ART that we can do to help this couple become pregnant. I mean, naturally, they are searching for solutions. They've asked people. They've looked at all sorts of possibilities, and they want a question. They want an answer to this very important question. We don't want to do IVF. We want to try and avoid it as much as possible. Is there any way in the world that we could help them in that sense?
So basically, this patient showed right-sided hydrosalpinx and the patent left tube. I think it's worth putting a scope. Okay, many times we can get chronic PID or even tuberculosis could be the accidental finding in such case. Usually, this disease are already bilateral. I mean, if one tube is affected, the other would also be affected. So cilia would also be get damaged. In case proper counseling is done before putting the scope, I think salpingectomy of the affected tube would be better. And then maybe we can give them a chance with the other tube. If they are not willing for IVF, even ovulation induction or time intercourse could help this couple.
So Shrutika, this lady and her husband, they are a very high-flying jet couple, and they are going abroad next month for a holiday, and they want to just finish the IVF quickly. Let's do it now, and then we want to go for a holiday. So what do you advise them? Tickets are booked.
Sir, I would only be able to kind of freeze the embryos and not do a transfer because it's a unilateral hydrosalpinx here. So ideally, before doing embryo transfer, if they're in such a big hurry, we need to still clip the tubes or do a salpingectomy preferably. So honestly, we can't really do anything for this couple in 1 month time. But having said that, when they said that anything other than ART would help them get pregnant, it's a unilateral hydrosalpinx that I can see on that HSG. Maybe they can try naturally for a month. It's not like having one hydrosalpinx is going to prevent any kind of natural conception for them. But yes, if IVF was planned, I would like to clip the tube.
Right. So the plan was that, this couple, since they had a fairly long trying time, they eventually did get convinced to undergo IVF. So let me ask Darshan. Darshan, now the choice is that we have to do the laparoscopy first. I think that's something which almost everybody agrees on. So what's your preferred option, in the sense, how do you manage the hydrosalpinx? Would you rather do a salpingectomy, or would you like to just clip the cornua and see that you make this a non-communicating entity? And how do you justify your choice? I mean, what's your point of view when you're making this surgical choice?
Okay, I think clipping would be a better option, clipping and draining the hydrosalpinx, because sometimes, when we are going for salpingectomy, blood supply of the ovary may be hampered. If we are remaining more towards the tube, then the blood supply hampering would be avoided. But clipping is a better option if it is not a big hydrosalpinx.
Okay. Anyone who favors doing salpingectomies?
So I would 100% want to do a salpingectomy in this case and send it for histopathology.
Okay.
We need to be prudent, as Dr. Darshan mentioned, that we need to be prudent about the use of cautery and bipolar here. But I think we are pretty assured about the safety here. We should not worry so much.
So the only time I would consider clipping is if there was any surgical difficulty where we see a lot of adhesions and it's difficult to do a salpingectomy. At that point, we would consider delinking or clipping.
Yeah, once in a while, we have these situations where the bowel is totally adherent to the tube, and it would be a major undertaking trying to do that bowel adhesiolysis. Even though you may have gone in intending to do a salpingectomy, you might come out doing just a clipping, and that should be par for the course in those kind of difficult situations. But yeah, I mean, most of the times, I think people would generally do a salpingectomy with a hydrosalpinx. But Darshan, point well taken, that you need to be really careful, otherwise you'll have a situation where the ovarian response can get compromised if there's an overuse of cautery and the ovarian blood supply has been affected. That's absolutely a known phenomenon which we've faced. So I get your point that
What I
you
feel
would rather
is
yes, Chaitanya.
yeah, what I feel is since a lot of people then read many things and they come prepared with all the points to discuss, you have to consider this point also, that salpingectomy may lead to reduced blood supply to the ovaries, leading to
Yes,
diminished
we
urine
did
flow.
that.
So,
Yes, that
so
point
in
was
this
well
situation,
taken.
delinking with drainage of the hydrosulfides is something which I also prefer, because nowadays people are so much anxious and they are much possessive about the tubes that even convincing them for salpingectomy is not that easy. Because though the guidelines clearly mention that any hydrosulfing should be removed, but convincing them for salpingectomy is very difficult. And in that situation, maybe delinking with drainage is one option where you can tell them that
No,
yes,
I mean,
I-
since we are debating this very important point, people who are pro salpingectomy, Kajal, are you one of them?
Yes, sir. I would
So
go
how
for
do you, what points do you put forth to the couple that, you know, you will have these benefits with a salpingectomy rather than just going for a clipping?
Sir, I feel that salpingectomy would be the better option because means I don't feel that clipping should be the option given unless, as we discussed, that if there are adhesions, I think better we go with
No,
this.
no, that we are on the same
Today's
page,
era,
but
yes, sir. In
no.
today's era, I would like to counsel the patient that now we have the ART facilities available. So now no need of keeping these the infected tubes inside the body.
So I think one of the thought processes that, you know, this is still going to be a pro-inflammatory kind of a state that you're leaving in the pelvis, and that's the rationale of recommending a salpingectomy. But I think you know, we could just keep debating this for another 10 minutes, and then Monica will call me and say that, sir, you hardly did anything in your panel. So I think time to move on. We've dealt with the tubes. Could I have the next slide, please? Yeah, so I think this is another controversial area, and Dr. Dabade and Shrutika did touch upon this aspect that if it's a unilateral hydrosalpinx, would you get the other tube out as well, or would you delink that tube as well and, you know, ensure that this woman conceives only and only by IVF, or do you give her a glimmer of opportunity of conceiving on her own? Nidhi, what are your views on this?
Yeah, sir, I would tackle only the unilateral hydrosalpinx. I would give them that ray of hope. But the problem with tubal pathology is it is rarely unilateral. Usually, if one tube is affected, there is going to be some problem with the other tube as well. But then doing it right away, removing of both the tubes is going to cause more mental trauma to the patient as well. So if I feel on examination at laparoscopy that the other tube is patent, it looks normal, then I would definitely want to leave it behind.
Okay, Rohan, any views on this? And then I'll go to Kajal, since she has the hand.
So this is a double-edged sword.
Absolutely.
As Nidhi ma'am said very aptly, that eventually it's going to be the patient's decision. Ideally, we would want to do a bilateral salpingectomy, but it's all going to be about your counseling and your conversation with the patient. If as you said, this patient does not want to go for IVF because she's a little bit, they still want to try naturally. So maybe consider only a unilateral delinking. But at the same time, as you have to counsel them that there is a risk of a pathology in the other tube as well, maybe during the HL scopy. Unfortunately, if you've spoken to the patient only about unilateral, you can't take an intra-op decision of doing a bilateral salpingectomy.
Agreed,
So
agreed.
whatever is spoken prior to anesthesia should be what you stick to once the patient is under as well.
Kajal and then Shrutika, if you have any new points.
Sir, I feel if we do a strong counseling, like when we see a hydrosalpinx, majority of them, both the tubes are affected. And if we explain them properly about the chances of ectopic pregnancy also, so I prefer that we should do a salpingectomy and then offer her ART treatment.
Both sides.
Yeah.
Both sides. Shrutika, anything you would like to add?
Add to what Rohan said, I think we can just mention to the patient that there is a possibility that the other tube is affected as well by whatever pathology is there, and
Yes.
just say that there could be an increased chance of an ectopic pregnancy at best. Beyond that, I think we can't push the patient in favor of a salpingectomy. In the absence of a pathology, it will be very difficult. Chaitanya sir just mentioned that for a hydrosalping also it is difficult. So with a normal tube, saying remove the tube because we feel that you should do IVF is very, very difficult.
Right, absolutely. I'm going to skip the next question. I'll go to the part about hysteroscopy. What abnormalities can we expect? This is a woman who obviously has some kind of a pelvic pathology. Let me start with Dr. Dabade again. Sir, what should a hysteroscopy be done? And if we are going to do it, what should we keep at the back of our mind, when we are going in with this kind of a picture?
So whenever we are posting these patients for laparoscopy, we would definitely get their good ultrasound, transvaginal ultrasound done. And if we are suspecting some pelvic pathology, I would not do hysteroscopy before doing laparoscopy. And if laparoscopy tells me that there is a lot of pelvic infection, I would probably defer doing hysteroscopy in the era of good 3D, 4Ds available nowadays.
Okay. Uterine pathology can also coexist. So yes, one way of ruling it out is a 3D, 4D. And of course, one could just put in a scope. Yes, Shrutika and Darshan.
Sir, I would like to rule out because see, in our country with TB being such an endemic disease, we can see adhesions intrauterine. We can see, this patient could have a coexisting thin endometrium. We should take samples, rule out tuberculosis, rule out chronic endometritis in this patient. So those are the pathologies.
There is some place for doing a histro at the same time.
Definitely.
Agreed. Darshan, anything new?
Yes, the same thing that Dr. Sutika said. And other thing which I wanted to add that we don't want to remove the laparoscope, but after doing hysteroscopy, again see the other tube also. If it has got dilated by injecting the fluid, so we can assess that that tube is also bad, or we can take the decision of delinking or salpingectomy.
No, but you know what? I think I would agree with what Rohan said over there that, doing intraoperative decision making, it's always there is an element of danger over there.
Yes.
And I would rather be quite clear about what I'm going to do and just do that. Yeah, I get your point that sometimes you discover something, but this is something which will really change her outcome. So fair. I mean, if you counseled her that I am going to do this, and then that's okay. But I think it's good not to make any on-table decisions which are permanent. Chaitanya, would you like to add something?
I think it is always hysterolaparoscopy. So you must combine the two, and you should actually take a biopsy as well to diagnose the tuberculosis.
Fine. Next slide, please. Let's move forward with this tubal infertility. Which patient, out of say 100 that you do like this, how many of them are you going to put on anti-tuberculous treatment? What are your kind of markers with why would you want to do ATT in this woman? How do you make that decision? Can I ask Shrutika this?
Yeah, so as per the latest guidelines, you cannot start ATT without ensuring that there is a tissue diagnosis of tuberculosis. Just on your perception, so I'm married to a pulmonologist. I know how serious the government is about AKT at the moment. It's a notifiable disease. So if you start AKT, you have to be very sure that the patient has tuberculosis. That means that you have to have a tissue diagnosis that says that there is tuberculosis. So the best test that for our case in Gynac would be like a gene expert, which we can send with the endometrium and a histopathology of whatever you see. So say if there are peritoneal deposits or if there is an infected tube, send it for histopathology. Also for MTB culture. like a bacterial culture or something, so that we can also assess resistance to drugs. And we should, as gynecologists, refrain from starting AKT ourselves.
Absolutely. I couldn't agree more with you, Shrutika. Dr. Dabade and Chaitanya, please.
Yeah, because as she rightly said, we need a tissue diagnosis. But remember, this tuberculosis genital is a possibacillary disease. We cannot always get the result from the laboratory. But yes, if visual inspection tells us that it's most likely to be tuberculosis, even the government doesn't deny you from starting anti-tubercular line of treatment.
So there can be a situation where there's a very strong clinical suspicion. And based on that, yes, but we have to take all measures to prove that tuberculosis exists in this woman.
I agree, but this being not a primary, tuberculosis genital is rarely primary. So it
Yes,
has come to GIT or pulmonary, and then the serosal surface gets affected, which is better visualized laparoscopically. And you may not really get anything on endometrial biopsy or tissue culture, what you do.
Yes, exactly. Exactly, that is what see. We started doing TB PCR since 2006. We are doing TB PCR. First, it was DNA TB PCR, then RNA TB PCR, and till 2012, we used to say that this is the patient who is going to get TB PCR positive and will start AKT. After 2012, suddenly there was absolutely no positive report from any labs, and it was really surprising. But that is what is happening since last 10 years. I have not seen any patient coming TB PCR positive. So then we started thinking about another test, and that was backtech test. So Ranbaxy patented backtech test is something which gives you not only it is a culture test, so it gives you idea about the resistance also. Then again, backtech test was also not coming positive, and then it was really difficult to correlate the biochemical or the pathological markers with the what actually you see on laparoscopy. So you know that this is tuberculosis, but you are helpless and you just don't know what to do. And recently what we have started doing is we have started giving tuberculosis treatment empirically, as Rajiv has rightly said. And we not only do that, we notify this to government also, and we keep our laparoscopic pictures with us to justify that clinically this patient is a case of genital tuberculosis. There are all the features of genital tuberculosis, but it is very difficult to detect it on pathology. But still we are giving this tuberculosis treatment because this is our clinical diagnosis.
Okay, let's move on to case 4. Next slide, please. Yeah, thank you. And these are, the typical head scratchers who come to our clinic every once in a while. 28-year-old woman, 44-year-old husband. They've been married since 8 years and have been trying since then. Normal fertility assessment, 9 semen analysis reports. I think he must be getting one every birthday or something, Sperm DNA fragmentation is normal. HSG, 2 reports, poor thing, both showing open tubes. Endoscopy has been done enough times for this woman. 2 hysteroscopies, 1 laparoscopy, all okay. Multiple times endocrine profiles, thyroid, prolactin, AMH, thyroid, prolactin, AMH. And the last one was 3.2, not too bad. So they've had 4 cycles of oral ovulation induction, 3 cycles of gonadotropin IUI. And next slide. This couple, they've had 1 long protocol with a negative beta HCG. They've had 1 thaw cycle from that long protocol. And again, that was a biochemical pregnancy which dropped off after a few days. And then she had an antagonist protocol with recombinants. She's got 3 embryos were transferred, unfortunately, again, negative, and she's got 3 frozen. So, now they are at the end of their tether, as one would think. Next slide, please. I'm sorry, the dates are a bit old, but this was an actual case which I took from an older presentation. So now, the question that they have in mind is that we've done 3 transfers at another clinic and, we still have embryos there. What do you suggest that, Dr. Dabade, this question is for you. I'm going to ask one question to one panelist now because we've got only 8-10 minutes left. What should she do? Go back to that clinic, get her embryo transfer done, transport those embryos to your clinic, or just scrap that whole thing and go for a fresh stimulation?
If she plans to go for fresh cycle, I think the husband is the culprit here. He's already 44-year-old and he needs good 3 to 4 months of good antioxidants to improve his. The count is not a problem here. Okay.
Okay.
Quality of sperms is a problem. And long back, I remember a slide shown by Sudesh Kamath in a conference, which embryo is good. On one side, he kept Aishwarya Rai's picture, the other side, Priyanka Chopra's picture, and he said, tell me who is more beautiful. It's very difficult just by visually inspecting to find out which one is good or which one is bad. And I would not blame the embryos, but I would blame the husband for this, and he should be given right treatment before the couple is taken for a fresh cycle.
Okay, Nidhi, how would you optimize the timing, of the thought transfer? They decided that, okay, we want a thought transfer. So what's your opinion, experience about ERA, endometrial receptivity assay? Do you think it matters for this sort of a couple? They've had, 3 negative cycles.
Sir, my experience though is very limited, but in this couple, definitely I would give them an option of ERA because they've had repeated implantation failures. And the first cycle we can, get convinced because they had a difficult transfer, and a good embryo transfer is vital to the success. But then hysteroscopy was repeated, it came back as normal. I think the second transfer and third transfer went on well. So definitely, I would like to bring the embryos back to my clinic, obviously, because I want the transfer to be done under my supervision. We would offer them an ERA in the previous cycle. And depending on the ERA report, we would like to optimize the time of transfer and not do a fresh cycle again, because that would increase the cost unnecessarily and again the time to pregnancy as well.
Okay, Rohan, you want to add something?
So in this case, as I agree with Dabare sir, that there's a possibility that the male factor could play a role mainly because of age, because there now are research papers talking about the mitochondrial aging even in the sperm. In this case, since she has embryos, I would maybe think about doing a sequential transfer for her rather than going for ERA in this cycle. If I go for a fresh stimulation, then I would maybe use ERA and then go for the transfer.
Okay, fair enough. Rohan, let me keep going with you. And, she gives a history that my first embryo transfer was terrible. I was on the table for half an hour and the doctor kept struggling to get the catheter in and I didn't know what was happening. So, when you've got couples who come to you with this kind of a thing, what are the best practices that, you want to adopt or keep in mind when you're going to
So ideally, we would consider a mock transfer for her. A small thing that I've seen with a mock transfer is that I always measure how much the bladder is filled. I actually do the volume of the bladder so that I can replicate that in the main transfer itself. Because sometimes we just look at the direction, but we don't realize that the bladder filling could be different at the levels. Number 2, what I would consider is doing an afterload technique for her rather than a preload technique, so that to ensure that the exposure of the embryo is as minimalistic as possible to the outside environment. Make sure that all my senior staff is there for the embryo transfer rather than any new people around. Hysteroscopy is really not going to help per se with the embryo transfer, considering she's already undergone 2 hysteroscopies prior. So we have an idea that there's no real pathology inside the cervical canal, guessing that it is normal. So these are 2-3 things that I would take into consideration while doing a difficult embryo transfer.
Absolutely. Next slide, please. So Chaitanya, there is a lot of debate and heat about, all sorts of adjuvants which go into doing IVF. And one of the very fashionable things that was around, say, 5 years ago was endometrial scratch. So would you do it or would you advocate it? Did you ever advocate it? What are your thoughts about it?
I delivered a talk on endometrial scratch in ASCOG 2016, And that time I strongly advocated endometrial scratch as the best treatment for recurrent implantation failures. But then yesterday guidelines came which say that the scratch does not have any role as far as the recurrent implantation failure and endometrial receptivity is concerned. But what I feel is still like the old era, people used to do DNC and people used to get conception with DNC. That was a practice which was done say 50 years back or 40 years back. Still there is a role of scratching because scratching does help by releasing of the implantation favorable cytokines and other things. And also it has got its role to increase the inflammatory response, which also helps in implantation of the embryo. And of course, nowadays we have started doing PRP injection into the subendometrial lining through hysteroscope in all the patients of recurrent implantation failure where endometrial factor is playing a role as far as infertility is concerned or failure is concerned.
Fine. So, I mean, PRP is the new scratch.
Is a new, and I would just like to add one point. As far as GCSF is concerned, we used to install it inside a cavity, but we have stopped doing that nowadays. We are giving it subcutaneously.
Right. Okay. So any other things that have been put into the endometrial cavity, except the embryos, sorry, which you think can make her pregnant?
I think considering all these,
first mock, then scratch, then PRP, then GCSF, and finally embryos. So
we forgot the era. So we forgot the era biopsy.
The era. Yes, sorry, I forgot that. So lots of things that are possible to do. Next, please. Kajal, this one is for you. So anyway, we are planning a thought transfer for her. And 3 embryos we thought started her on progesterone on the appropriate day. All 3 are doing well, they're nice, top quality embryos. Now, what do you think we should do? Should we just transfer all 3 of them or wait till they hit blastocyst? What are your thoughts?
Sir, as we can see that the quality of the embryos is good. They are all grade A embryos. So I think as she has a previous 3 cycle failed, so we can wait for the blastocyst transfer.
Rajiv sir has talked about male factor. दूध का दूध पानी का पानी हो जाएगा if we wait.
Darshan, you want to add something here?
No, blastocyst transfer is the best thing which we are routinely doing in each and every patient. Even if we have only 1 embryo.
Wow, that's quite an approach. I'm sure that you must be talking to the couples that there's a chance that we might cancel and so on and so forth, which is one way of going about getting them pregnant. So fine, yes, Rohan.
So I would want to do a sequential transfer because she's a recurrent implantation failure where maybe we do 1 day 3 transfer, keep the other 2 embryos for culturing and then do a blastocyst transfer after 2 days. We've been doing it at our center for quite some time and we are seeing promising results, especially in recurrent implantation failure. It's a way of covering the ERA process as well.
So it's like, you're hedging your bets. You don't know which way it might go with trying for a blastocyst all through. So fair. I mean, that's another approach.
Let me add that in the era of Google, all the couples generally they do the Google and they know that day 5 is always better. And already this patient previous 3 cycles are failed. So generally patient comes and says that we want to go for day 5 transfer. That is also I have seen in my practice.
I agree. There would be an element of patient choice at this point because, I think now they get an equal say in the matter because thrice what we've done has not worked. So might as well go with what they are saying, which makes sense. Now I'm going to throw this open to anyone else who has any other ideas what we can do with this couple. We've done the usual gamut, but say there was no restriction on resources, infinite money, no problem. Anything that you could do in the lab which could change the outcome.
PGTA is something that we can consider pre-implantation genetics for this patient.
Atosiban also we can start for this patient.
Okay, why not? So I'm just running through a list. I'm not saying good or bad, but
so luteal phase support, add
Part of
your
the workup for recurrent implantation failure would be also ruling out thrombophilias, antibodies, autoimmune conditions. I think we've spoken about everything except for that. So the immunological causes and the antibodies and that aspect maybe we can look into. But I agree with Rohan ki pre-implantation genetic analysis ideally is looking for ruling out aneuploidies.
Shrutika and Rohan, just one tiny this thing. You know, these are thawed embryos.
We can,
now,
so as I said, so
maybe not, but in the future.
Yes, sir.
We could think about it in the future.
fresh cycle.
Like a fresh
In a fresh cycle, we could do that.
If we are having third day embryo, so we can go for non-invasive PGTA. Media spent from third to fifth day, we can send it and have a result. But again, you have to again freeze it and then
I think
transfer.
that is very little media.
So,
so may not work in a third cycle.
So in addition, NIPT is a screening analysis. It's not like a diagnosis. So it would give us a risk assay rather than a.
So I think it's very obvious that, you know, we are all going to be just groping around in the dark with these embryos in the lab. Yeah, Chaitanya, you want to add something?
The only thing which we have not discussed is lead therapy.
Sorry?
LIT.
LIT.
Leukocyte immunotherapy.
I didn't know that it has now invaded into recurrent implantation failures also. I thought it was restricted to recurrent miscarriages.
No, sir.
So
recently,
it's being done for this too, huh?
Recently, it's just been started.
Okay. So it's too recent, you know. I mean, I don't know whether it really has a role at all or not. So I think we ran through a laundry list of, you know, everything that we could possibly think of. And I think it would be a wise decision to have a good counseling session, take the couple through the various options, various interventions that we could possibly do, pros, cons, and, you know, then come up with a treatment plan. So as I said, this couple is a real head scratcher. And could I have the last slide, or is this the last one? Okay, I think that was the last slide. So a very warm thanks to all of you for utilizing your expertise and your experience in responding to these questions. These are really, you know, dilemmas that fertility specialists do face every now and then. And we do our best to try and optimize the results of IUI and IVF treatments for couples who have so much at stake. So my thanks to Satabdi for taking the load for half the panel. And it's a pleasure to be with all of you this evening and signing off. Over to Monica, please.
Thank you, sir. Thank you so much for such a brainstorming session. I am sure the delegates would have definitely a lot of take-home messages with these two panels. We thank our chief guest, Rishma Pai ma'am, Alkesh Gandhi sir, and Rishikesh sir for joining in blessing this webinar. I also thank Nandita madam and Rohan who chipped in at the last moment for the lecture. I would also thank Kalyan sir, Parikshit sir, Shatabdi and Monica Gupta madam as the moderators, Dr. Leela Vyas ma'am, and Dr. Kamini Patel ma'am as the experts. I would now request Dr. Monica Gupta madam to please officially propose the vote of thanks.
It was a nice webinar, and I thanks all of the persons who have participated in the program. I especially thank the PAC committee for organizing this event, our chief guest, Dr. Rishikesh Pai, and our guest of honor, Dr. Rishma Pai, for this, and our first speaker, Dr. Rohan Paleshkar, who on the last moment gave consent to deliver the talk, and the chairperson for the group, Dr. Ajay Mane and Dr. Narendra Gupta. First panel, Dr. Kalyan Bagpate and expert Dr. Leela Vyas. I thank all the panelists, Dr. Vishal Gude, Dr. Snehata Dubey, Dr. Shailesh Jain, Dr. Desh Deepak, Dr. Charu Johari, Dr. Bansi Shinde, Dr. Manjari, and Dr. Priya Kadam. And the second panel, for the second panel, panelist moderator, Dr. Parishit Tank and Dr. Shatabdi Dey, and the expert, Dr. Kamini Patel. I thank all the panelists, Dr. Shrutika Thakkar, Dr. Chaitanya, Dr. Rohan, Dr. Rajiv, Dr. Darshan, Dr. Kajal, Dr. Nidhi, and Dr. Monica, and a special thank to Dr. Monica for organizing such a wonderful webinar. I thank the Corona people for organizing this meeting. Thank you, everyone. Have a good night.
Good night, everyone. Thank you so much for joining me.
Thank you.
Thank you, ma'am.
Bye.
Bye.
Thank you, everyone. Thank you, Parikshit sir. Thank you, Monica. Thank you, Kalyan sir.